Yes. Good Sunday morning, everyone. Right where I am now, it's quite sunny, and I hope you're having a great day. It's a beautiful day today. Also, greetings to our distinguished panelists, and especially our guest lecturer, Professor Shibuya Musa. And as usual, thanks so much for all who have decided to attend our webinar today. We don't take your devotion to attending our webinars lightly. Thanks so much. All right, let us pray. Almighty Father God, loving, protective Savior, thank you so much for this beautiful day, Lord. I pray that you will just be with the proceedings today, Lord. Just help it to run smoothly in every way. I pray that you will just help us to have clarity of mind as we listen, and we will grasp all these important subjects in a way that we can be of greater benefit to all of our population and all of our patients. I pray that you will be with the IT process, that it will run smoothly, we'll have no glitches, because that is so important for the delivery of this seminar. I pray that you will be with the moderators. I pray that you'll also be with our presenters who you have blessed with such great talent, dear Father. I pray that you'll just continue to also bless our sponsors who have come on board, because without them, we cannot do as much as we would like to do. So we are eternally grateful to them. I pray that you will just help us to also continue, to really try and, help as many in this great pandemic that is going on right now. I pray that you will be with those who have been infected and affected with COVID. Help them to have complete recovery and console those who have suffered loss during this time. I pray that you'll also be with the ministers and those in government and guide them in their different decisions, dear Father. I pray that you'll continue to just wrap your arms around us and protect us. All these things I pray for in your Son's precious name. Amen.
Amen.
All right, thank you, Maxine. I think it's now time for me to take the baton from you. So good morning, colleagues. I'm Professor Marvin Reed, Chair of the Caribbean College of Family Physicians Regional and the Wonka North America President. It is indeed my pleasure to welcome you to this particular episode of our webinar series. And in particular, I would like to extend on your behalf a sincere gratitude and welcome to Professor Shibuya Musa, who is the president of the African version of Wonka, and I'll introduce him more fulsomely after greetings from Dr. Seni Onanuju. So I'd just like to thank you for your participation and for being here today. I would just like to also use this opportunity to do a public service announcement, and that is for those physicians and nurses who are on call. The Ministry of Health is asking us to help them in the vaccine rollout, and they're asking us to register to participate in the training session, as well as to volunteer our time and service in the distribution of the vaccines. In a few minutes, I'll be posting the link that we have established, the Google form that we have established to gather the data. And we will appreciate you completing this by later today or early tomorrow morning so that we can share the information with the Ministry of Health. So again, just thank you for being here. And I'll now hand over to Dr. Seni Onanuju, who's the president of the CCFP Jamaica chapter, to bring greetings.
Specially invited guests, esteemed colleagues, our sponsors, friends, ladies and gentlemen, a pleasant good morning to you all. It gives me great pleasure and honor on behalf of the Caribbean College of Family Physicians to bring you greetings and welcome you to this morning's webinar. It is a joint conference where the local chapter joins forces with the regional chapter with the hope of striving for excellence in patients' care and management. As the theme suggests, it is a distinguished lecture series on chronic non-communicable diseases with emphasis on diabetes. Why diabetes? Diabetes is a prevalent metabolic disease responsible for a heavy burden of chronic illness, long-term disability, and premature loss of life throughout the country and the region. In Jamaica, approximately 11.9% of persons 15 to 75 years of age have diabetes. The prevalence increases with age and affects more women than men. The high prevalence and significant burden of the disease in our country and our region has not gone unnoticed. This explains why the Caribbean College of Family Physicians locally and regionally has jointly decided to organize a special workshop on it with a view to inculcate the fundamentals of the management of diabetes in the frontline doctors, especially during this time of COVID-19 pandemic. We hope that the knowledge garnered today will help us to optimize the management of patients with the condition. To this end, we have a lineup of interesting presentations and great presenters who bring a wealth of knowledge in the management of diabetes and its complications. The Caribbean College of Family Physicians deeply appreciate this gesture of all our presenters, and we thank them for giving of their time, talent, and experience to participate in our distinguished lecture series. As such, we have in our midst a distinguished international speaker who hails from South Africa, Professor Shibuya Musa. Thanks to Professor Marvin Reed, our regional president, for inviting him to share his experience with us today. Professor Musa will welcome you to this distinguished lecture series. We also welcome all our distinguished local presenters, Doctors Patrice Francis, Emmanuel, Jeffrey East, and Adedemola Soyobo, and Professors Brendan Bain, Michael Bowen, and Marvin Reed. Special welcome to all our members. Despite the ongoing challenges caused by the COVID-19 pandemic, the CCFP membership and their support remains strong. The collaboration today of the local and regional chapter is an excellent example of this. I wish to extend on behalf of the CCFP board sincere gratitude for their support during the past year and look forward to their continued support during the remainder of this year and those to come. We also welcome all our attendees present and those to join us, our sponsors, our administrative and IT team, and all those who helped in making today's webinar a reality, thus helping to deal with a condition which is an epidemic in our nation and in our region. On behalf of the college, I thank you and I welcome you and I invite you to sit back and enjoy the presentations. Thank you.
I would like to thank Dr. Sene Onanuju for those kind words, but just for a brief history, last year at our CCFP triennial meeting, we had taken a decision that each year we were going to establish what we call a distinguished lecture series, where we would invite eminent family physicians to present on a topic, relevant topic that we would choose for that particular year. So it's indeed my pleasure to welcome Professor Shibuya Musa to deliver the first of what we hope to be many distinguished lectures on behalf of the Caribbean College of Family Physicians. So Professor Musa is a family physician who has both an MDA and a doctorate. He has extensive experience in rural general practice and the development of family medicine and primary care services in both rural and urban districts health services in South Africa and in Africa as a whole. Shibuya is deeply involved in the development and research around family medicine and community-oriented primary care in Johannesburg, Gauteng, and Africa. He's the president of the African chapter of Workup, which is the World Organization of Family Doctors, and he's the facilitator of Africa Primary Healthcare, otherwise called Afro-PHC, and he brings PHC team leaders together to advocate for primary healthcare and universal healthcare. So it's indeed a pleasure of mine to welcome on behalf of the college, Professor Musa, who will be presenting on really how the African system is structured and geared to address the non-communicable disease, in particular diabetes. Professor Musa, all over to you.
Thank you very much. I'm really chuffed by that introduction. Thank you, Marvin. Thank you to all the senior leaders of the CCFP and to this audience for taking off a Sunday to listen to this. I'm going to share this presentation. I hope I can, but it looks like I can. Thank you. So let me just dive in and, sorry. It's quite a few slides, but quick to go through. Yeah, so I've been asked to talk about primary health care and how the health system addresses health problems, in particular chronic non-communicable diseases. And essentially, I've gone about trying to put it together as to clarify for you the global burden of disease and what it is about NCDs as the burden of disease and particularly risks. The second thing we'll talk about is the NCD response, both globally and regionally. I'm going to deal with a model of care, which I think everyone should be aware of, but just to remind people of the chronic model of care, chronic care model. And then I'm going to share some African thoughts about how we tend to deal with chronic disease and what are some of the challenges. So in terms of the global burden of disease, this is just from the IHME Global Burden of Disease, the website Our World in Data, and it shows quite clearly the enormous burden of disease that exists in Africa. And that for neonatal maternal infectious disease, it's kind of known, Africa. Yet, in fact, in terms of non-communicable disease, Africa is also quite substantial. Now, that may be because it actually has much more disability from the consequences of non-communicable disease. But I think that people must be aware that Africa is, in fact, struggling quite considerably with non-communicable diseases. The global disease burden has actually been shifting, and communicable diseases have been declining with the attention broadly, globally, I think for the last 40, 50 years. But non-communicable diseases have been climbing and in fact exceeding now quite substantially the communicable disease burden. And the way in which it is in fact moving along is cardiovascular disease and cancers are becoming the large burden of disease, and we need to ask ourselves, how are we responding to those kinds of conditions? So in another spread of that, you can see cardiovascular diseases at top of the pops with cancers next. But I mean, amazingly, neonatal disorders are still part of it, albeit not non-communicable disease. But there are an array of non-communicable diseases which we need to be aware of that are there and that do cause disability and debilitation in our patients, musculoskeletal disorders, mental health, and other non-communicable diseases. And you can see a couple of them down the line. I think just to contextualize it, I share in this slide the total burden of disease burden by cause in Jamaica. And this is, of course, 2017. But you can see quite notably cardiovascular disease and cancers are definitely like what is going on globally. But neonatal disorders are actually quite part of it. But you can see the rest of it's the kind of non-communicable disease representing what is the global burden of disease. But in Africa, we still have that global burden, that total burden, disease burden being limited by communicable diseases and maternal and child health. So just to give you a nuance of the problem, that we have this growing burden of disease, but are we ready for its impact? In Africa, while it looks like this is not the biggest problem, is definitely a growing problem. I think just in terms of the costs that come from non-communicable diseases, this in fact says that the cost is in fact enormous when you look at African countries. I want to also share with you that risks are as big a problem as the NCD disease itself. So non-communicable disease is one thing, but the fact that risks are actually emerging, and these are something we need to look at. So you can see the range of it in front of you. Whether genetic, environmental, socio-demographic, self-management, and medical conditions. But the big bear in the room is in fact self-management. Those choices that people are making that are in fact presenting serious risk. And when we look at these risks, the one at the top is dietary risks, followed by high systolic blood pressures, tobacco, and our glucose and blood boy BMI. So these are the kinds of things that people themselves can make decisions about. And we need to be able to, as family physicians, ask what's going on and how do we be part of the solution. I think it's also increasing in that range in terms of risk factors. So what was before a relatively small risk, this becoming an enormously high risk as we're going along. So you can see that lots of things are moving to the top, and blood pressures, glucose, and high BMIs and cholesterol are the ones that are creeping to the top as risk factors globally. And I think we know that in our practice. I think just to share with you that even though Sub-Saharan Africa, as you can see right at the bottom, has only body mass index as a high indicator of risk challenges in Africa, Caribbean is really very different. And I think you need to note those kinds of things are already substantial risks in your space. Why is Africa not having these risks necessarily as it seems? It's a lot because we have a younger population. And the fact that we have a younger population perhaps is saving us now, but it says that the risk as this population starts getting older is going to be a big, big problem for Africa. UHC, and that's the response of the health system, is definitely not on par with the risks and the diseases burden in Africa. And I think that's known that we are struggling in Africa to get UHC systems up and adequate to the demands of the population. And this just echoes that same problem. You can see this is kind of similar to Haiti and other parts of the Caribbean as well. And I think this is a little bit more detail around UHC effectiveness in Cncd, and it is poor compared to places like Iceland and other, OECD or developed nations. And that Guinea, as an example, is really poorly off, and you can see how bad it is off. But I was quite surprised, although I can understand from the context in the Caribbean that Haiti is as bad as some parts of Africa. That's not all bad news. I think that in Africa, there has been in the last 10 years concerted efforts. And I think we are fortunate that there is an attempt. So you can see that as compared to the movement in the first decade or 1990 to 2010, and then compared to 2010, 2020, Africa is in fact having more action, more visible changes in terms of UHC coverage. So I think that's the kind of thing we should be saying, well, hang on, good news. The NCD response, globally, there have been, and this is a response that's global as well as country level. And we need to appreciate that as family physicians, this needs to happen not only at the individual level when we meet patients, but in fact at a society level in the context of our patients. But the WHO, as an example, has got a directorate with Dr. Bente Mickelson there, and they're doing some good work. I think there's an array of structures that have been set up, and there's a global coordination mechanism. You can see a whole range of them that are out there that the department or the NCD department in the WHO are trying to get happening. Key decisions that have been made globally have been in 2000, when I think there was this awareness that really non-communicable diseases, after all our attention over the last 50 years on communicable diseases, is growing and becoming a real problem. And so by 2008, together with the 2008 report on World Health report on primary health care, this non-communicable disease was brought in. And in 2013, there was a UN General Assembly to a high-level meeting on NCDs. And this basically put NCDs on the map. And in fact, that has been incorporated in target 3.4 into the SDGs as a target to say NCDs, we need to do something about it. There have been documents that have been developed, tackling NCDs, try to look at these best buys, which are more or less incorporated, addressing diet, exercise, and alcohol. And in a way, that has become quite core to the Global Action Plan, which the WHO drafted. And some of the key objectives in the Global Action Plan are, and this, of course, you must remember, is at a high level globally, is the prevention and control of NCDs. There was an important focus on strengthening national capacity, and you'll see that in some of the work being done, and reducing risk factors, which I think is quite important, and then to try and orient health systems to deal with this. And I think importantly, the integrated primary health care that is mentioned there, in that through people-centered primary health care and universal coverage. Of course, research and data become quite important at a global level. There have been these 9 voluntary global NCD targets, and you can see they range from medicines, technologies to focus on diseases and the conditions themselves, physical inactivity, diabetes, hypertension, etc. With a whole lot of, whole monitoring framework that is set out to be able to say, are we achieving things with the indicators that are on the right-hand side? And I'm not going to focus on this. This presentation will be available, and you can have a look at it. The NCD Directorate in WHO have actually, labeled this their signature activities that they lay out at about 12 activities. What is really notable is that they're focusing or trying to focus on integrating and scaling up NCDs in health services, and I think particularly primary health care services. And this is quite important for African primary health care. So in that sense, the NCD Directorate talks of integrated primary health care, integrating NCD management into primary health care to be able to create people-centered primary health care approach in our achievement of UHC. And in there, unfortunately, when one looks at the literature that comes up, when one looks at the kind of activities that are happening in the WHO and related forums, the 15th, the UN Interagency Task Force on NCDs is in fact the place to listen to. And in the last meeting, what they were more focused on were finances and taxes, seemingly addressing these large public kind of initiatives in NCD management. The Directorate has also shared what I think quite useful, which is their essential non-communicable disease package, what they call PEN, and it does have guidelines that are there for the globe. And in Africa, that's actually quite important, because when I shared with you just now what's going on, you realize there aren't even guidelines in African countries. Nonetheless, I think this is an important intervention but it is guidelines at the very best. So when one looks at implementation globally, yes, there's a good amount of guidelines at the top that is being implemented, and a whole range of different things that are being implemented, but they're not all implemented completely well. And I think that is a function of political will and, in fact, politics and sometimes finances and the political economy around some of these risk factors. Fortunately, there have been quite a aggressive behavior in amongst governments to be able to look at these alcohol and diet kind of interventions at a national level. And you can see that tobacco mass media has become globally quite an active space for implementation of non-communicable sort of action at government level. PAHO, and I thought worth sharing it to you, is in fact got also at a regional level, some sort of action, something that I don't find very easily in WHO Afro, in which they have a plan of action for the prevention of non-communicable diseases, and in which they have an array of material complementing the global WHO. And you can see the areas of work that they do, providing policy briefs, being able to provide publications as well as graphic materials. And I think that in their NCD innovative management, which I'm going to share some things, they talk about the chronic care model. And in particular, they talk about the 5 A's, which I'm going to talk a little bit about as well, because it's a universal tool for improving the care of chronic patients with chronic conditions. They do, fortunately, talk about the need, as was said in the global policy gap, to look at health system responses, and they do talk about the need to focus on primary health care, particularly self-management and prevention. And it's something that, as you, as advocates in that space, should be using to sort of improve the way in which they integrate family doctors into the response. In Sub-Saharan Africa, this is a publication by Boudreau, and it basically did an audit of all the sort of policy response. And you can see that there's a fair number of countries that have a strategic plan, which is great. Some don't, but more have than don't. Unfortunately, the way in which the policies, and I'm sorry for the busyness of the slide, but if you just look at the slide and just see that, for risks, tobacco, alcohol, diet, and exercise, the percentage that are actually, aligned with the global efforts are actually quite limited. It's just tobacco. Otherwise, the others have lots of gaps. And that's the same with management in terms of cardiovascular disease, diabetes, cancer, and respiratory conditions. So there's a serious problem in Sub-Saharan Africa, even at a policy level, to be able to align ourselves to good practice globally. And that is quite a challenge. And this is, in fact, even extends to, details around being able to address how, salt consumption, fat consumption, sugar consumption, and even simple things like cardiovascular disease, the way in which screening and diagnosis occurs. I'm sorry for the busyness. You can have a look at these slides later, but I think the point is important, is that we have serious gaps in policy in Sub-Saharan Africa. And this was a study by Tisema et al., who basically did, looked at the question of progress of Sub-Saharan African countries against WHO regional targets. And no country met the recommended indicators to integrate NCDs into PHC. And I think this is the key problem in Africa that we suffer, is that verticalized programs are actually the norm, and integration is literally non-existent in many places. And despite efforts at integration, it still persists because of the structure, organization of healthcare in Africa. You can see the rest of it do not speak to very confidence building in the systems in Africa. So I'm going to talk about the chronic care model and then share some African thoughts later about managing non-communicable diseases. So you're fortunate, the WHO in PAHO is actually, in a region is actually addressing this, and this is a publication that came, or the idea, the slides I've actually taken from there. but it is an American concept. This is a study by De Villiers or a South African that talks about the ecological model, and I think in some ways there are different models out there. This speaks to something that is quite easy for us to think about. We know that health problems are not just a disease problem, that it comes from behaviors which are individuals who have all sorts of determinants, whether it is personal or beyond, as well as the environment, the context, and this might be whether it's around their family or community or beyond. And I think that's just us saying, well, that's family medicine. We also know that primary health care is not as simple as all that. And this is the systems modeling. It's complicated looking, but the point is that, in fact, people tried mapping this out. And just the simple management of non-communicable diseases in our relationship with patients is, in fact, complex. And I think this simply tells you just how complex it can be. And I think that that's the difficulty in the system in Africa, is that there is no appreciation of the complexity of the interactions between caregiver and patient. The chronic care model, and I think it's worth sharing with you and reminding you, it's in your setting in PAHO that they have encouraged it in your countries of the region. But it talks about health system and ways in which the health system can be supporting that interaction between the patient or the team and the team and doctor, or team and patient, and then the community as a context. And that's the way in which you'd get some of these better outcomes. So on top of it is, in fact, self-management, in which we need to be able to, and I think this is, again, things that we're all familiar with as trained in family medicine, is to ensure that the patient participates in the process of care, and that we look at in terms of the community space, whether they have peer or lay educators, to use group visits as a more efficient way to manage care, and to actually to help people to develop peer support. To help patients to develop self-regulatory skills is, in fact, part of that scheme of things. So it's not just education, but skills around how they manage themselves. In terms of self-management, this requires good patient communication skills, and also being able to help patients develop goals, and getting them to, in fact, see how they might be able to monitor themselves, especially in terms of goals that they set up themselves. We should be helping them through either the visit or the group or the community or the lay educator to find ways in which the environment can, in fact, be modified so that they can deal with those inhibitors in the environment that we said are part of that ecological model. I think ensuring self-reward, and this might be as simple as empathizing and complimenting, that we learn, or that we should be doing in collaborative care with our patients, and dealing with the social support as context as well. I'll come back to the use the 5 A's, but this is part of the chronic care model that is spelled out by the PAHO in their documents in the innovative care for NCDs. Delivery system design is also a second and very important one. And this is about organizing a care that is primary health care based. So in other words, it's not just primary care dealing with the patient, but dealing with the context of the patient in the practice. And there's more details around that. But one has to think, how am I not just giving medicines, but thinking about all the elements of it. Importantly is the team-based approach, that we actually do not and should not be only doing this ourselves as doctors. We should be looking at other team members, including in the community, like community health workers, and finding ways in which we can do proactive care with follow-up. And importantly, being able to think about how we can, in our system of care, give risk stratify. And this might be with our community health workers in the community or in our rooms, that we need to think about. And then to think about us giving that care through case management. And that case management is actually not in the practice, but in the community. And being able to have that care done in a way that through a community health worker and perhaps a nurse doing case management, to be able to have them understand the patient's context better, and then give them the care in that context that's sensitive to that context, but also links them back to the service that they get at the clinic. And this is very much good practice. Decision support is a third element in the chronic care model. And I think it's about saying that we need to not be making decisions based on expert advice that we received 20 years ago, but looking at the evidence today and being able to look at guidelines that are based on the evidence and that are technically sound, ways in which they've been achieved, and that we in fact are able to use them knowing that they are the latest, and that they are able to be part of practice and in fact very amenable to practice. I think the idea of shared care modality is that we try to look at sharing the care amongst team members as well as the patient. And that means that we need to be able to support our colleagues, nurses, community health workers in that approach of managing patients. So it's not just and it's not just you dealing with it, but healthcare worker and patient as well. This all needs a clinical information system and not necessarily an electronic system, although that improves it considerably. But it's having even chronic care records, simple hard copy based in your rooms that are catered to that, where you're able to say, how is my treatment actually moving along? Am I getting what I need to get in response to the treatment? And where you can gather information to in fact say, well, if I look at my diabetics, this is what my outcomes are like, what my HbA1c is like, and be able to find ways to remind patients, to remind the provider to say, hang on, did I do my HbA1c? This person's actually, I can see my chronic care form that I should be doing the HbA1c and it's 4 months on or 6 months on, depending on my my guidelines, and being able to look at that data to say, can I find segmented, it's like marketing, segmenting and targeting your population so that you really get your best bang for buck. I think that even good record keeping systems help you to care for patients and to share that, especially when you are not simply individually managing all your patients, that you have a team around you. It helps to coordinate and actually see how everybody's functioning and make sure that things are moving along with reminders. So the healthcare organization as well, I think, is that, depending on the kind of scale of organization one has, and, in a small practice, they may not be as big, but the issues are still, just as important. But in some larger practices, this becomes quite important, especially in what is common in Africa, which is large, community health centers where they can't manage, very personalized care. But that means that we've got to have improvement being supported right from top down, and not just be simply trying to, chase your tail to get, a bit of batteries, because no batteries available for even minor equipment in the facility. To be able to look at quality improvement as a way to get change and actually robust quality improvement, and have in that process an ability to deal with errors and problems and be sensitive about the way in which that is being done, in the team, and to find ways through an organization, hopefully, that is that you have the ability to do so, to provide incentives that improve quality of care, and way in which you can actually build agreements with the levels of care, the team itself, and then the levels of care, to be able to improve quality of care. Importantly is that, like we talked of self-care, there's an extension of that you need to go beyond into the community and, in fact, try and ensure that the community itself is organized, that there are partnerships with organizations, that you actually set up programs, that you advocate for it, that NCDs are important, and provide and link up your coordinator with these kind of groups in the community to support both in terms of your patient's self-management as well as social support. And I think these are elements out of the chronic care model, which I think is very similar to the kinds of things that we are doing in my practice anyway, and my space. So how well is South Africa, Sub-Saharan Africa doing? And this was a systematic review of primary care models. And yes, there's lots of these concepts that you can see that have been there before: case finding, modifying risk factors, and you can see essential medicines and decentralized care, etc. But a lot of these concepts are not implemented very well. And in fact, when you look at these new concepts, quality improvement, health system, decision support, these might be creeping into, into the space, but these are relatively new. What is quite surprising is that, and not surprising, but really common, is that there's still this idea of task shifting, but dedicated processes in terms of delivering of NCD care. And you can see in the block at the bottom that there is still a concept that is still being hung on to, whereas opposed to integrating around patients with the multitude of disease and multidisciplinary care, but still managing patients in this comprehensive fashion. And of course, as family physicians, we know these principles of family medicine, where we are committed to the person versus the disease. We manage common diseases and procedures. We know that subjective issues are important. We look at our patient's context to try and understand what's going on, and we think about prevention at every contact. In terms of being able to relate to the community, viewing practice as a population at risk is the concept. I think many times we tend to reduce it to thinking that's just simply, data in our population of patients, but I think we have to think of population of everyone that is coming to us. And many a time patients don't come and we think, well, they're not our problem. And I think that's the key problem we need to understand. If we're truly to be community oriented, we need to see entire population, that patient who is coming to us all the time, little at a time, or not at all. And I think that's really that concept. And I think in addition, the community-wide network is a principle of family medicine, being effective as a clinical manager or as a manager of resources, teaching others or mentoring others, and learning yourself. And I think these are increasingly becoming included into the discourse. The World Health Report on PHC in 2008 tended to talk of it, include elements of service delivery reform to say, really, we need individualized care. Astana Declaration does do that somewhat, but perhaps some of the elements get lost. And they talk more of people-centered care. Still an important concept, but in which we need to say what person and patient-centered care means and put that all together. In the African continent, as family physicians, we sit with patients and deal with the care that we give with patients. But we are not enough, and as a result, we are really torn by the need to bring in the team and be part of the team. And in fact, in that process, some of these team elements become quite important, as opposed to us delivering the care. We're very cognizant of the fact that in Africa, their priority diseases and NCDs become an important priority. And we constantly harp on the fact that patient care needs to include that, teams need to include priorities, and guidelines are an important element of the way in which we see ourselves relating and functioning. And thirdly, what is really important, but that we struggle to do in Africa, is the community orientation. And I think that is also a function of the resource constraint. We're not enough of us, but there have to be ways in which we as family physicians harp on that, talk of that, insist on it, and find ways to make it happen, even at small scale, to be able to demonstrate its benefits and to convince ourselves, I think sometimes, that it does produce a benefit to our outcomes. In terms of family medicine training in Africa, I think this is from the Handbook of Family Medicine, a common undergrad, postgrad training manual handbook. Basically, emphasize that families, in fact, as opposed to health providers, are primary caretakers of patients with chronic disease. And that's simply because there are not enough of us. And so patients have to actually get care about themselves. And so when we engage with patients, we need to engage the families so that we can get them to provide the kind of care and support to that patient. Adherence challenges, we have lots of them in Africa, and these are not just because patients don't understand, well, they do need to understand, but there are things that will go beyond them as choices go, to costs and the fact that they're lining up, having long lines that they deal with and that make them lose interest in following up their monthly visit or 3 to 6 monthly visit. These chronic management principles are within the teaching that we do in Africa, where we say, we need to be committed to the principle of family medicine, committed to the patient, because these can be very frustrating patients, those with the non-communicable diseases, especially diabetes. Continuity of care, is important, and that might be not just personalized continuity of care, it is institutional information continuity of care and institutional management continuity of care as well. And so we try to bake that in. How can we make sure that we do get the care managed? And that lends itself very strongly to the coordination, collaboration, not only between ourselves as the team, but in fact, other parts of the healthcare system, other levels of the healthcare system. We do think it's very important in our context in Africa because of low literacy levels that patients understand it. It is quite amazing that patients will come in and say, I'm on diabetes treatment and for 10 years and they don't even know the medicines that they are. We need to be able to educate them and tell them how important it is. And in fact, we spend a lot of time and energy in the workspace I work to teach community health workers to ensure that they understand it. And to be able to go and help them with the change that is necessary, because a communicable disease is a death sentence of sort. It might not be instant, it might not be short term, but it means some dramatic change for the patient. But it also means that the patient themselves are going to have to change things. They're going to have to change behaviors. And so that kind of thing is not easy to achieve. And we need community health workers also to go out there and support them in that change. Again, like we've talked of before, we also emphasize clinical guidelines and adherence to them and local protocols that are much more suited to our circumstance, but that are making sure that the quality of care is at a bar. And then capturing information, which is not at all easy in our circumstances where we're dealing with pieces of paper that are new every time you see the patient, most African settings. The 5 A's I'm going to just go through with you, and I'm just going to be trying to weigh off time. So 5 A's in each consultation is something I mentioned that the PAHO teaches in the innovative care, that is in the innovative care of NCDs, and that is actually quite commonly taught, even included in the textbooks in Africa, in South Africa. The 5 A's are basically to assess the patient's beliefs and knowledge, and to then advise them, hopefully with a motivational interviewing approach where you are not telling them, but actually exploring with them what the health risks are and the benefits of change are, and to find ways in which you can develop goals, hopefully that they can generate them or you generate them, but in which you can set these goals and agree to goals that, okay, let's set them, let's agree that you will do X, Y, Z, and that's what you find, done collaboratively. There's always the need, as we said, to help them both in their settings and personally about what are the barriers that they experience, in which you can get them to overcome these barriers that are barriers to their improved behaviors, self-management behaviors, and then also their care that you can arrange and link them up to other things as well as your continued care. So 5 A's is a very useful model to use in a consultation, and that PAHO is actually included as well. The 4 C's of chronic care consultation is actually what I like emphasizing in the 5 A's, and often is what really matters is that when a patient walks through the door, we often listen to their complaints, and they come in as a chronic care patient, and they say, we've come for repeats. Well, that's fine. Do you have any other problems? And sometimes they may say, well, actually, I've got a cough or do you have any problems? And they tend to say, I have a cough or I have some other problem, but they don't tell you whether they have problems with their NCD. And I think one needs to, in fact, emphasize, hang on, in terms of your hypertension, are you having any problems related to that? And that is something we need to be aware of. Are there symptoms that might indicate decompensation? Important in that conversation is to be able to look at the compliance, and adherence might be the better word, but to say, how well are you managing your medicines? Are you taking them well? Is it working out well? What's missing? And getting an understanding of their context in that process. And then control is obviously when you're looking at your record and you see what's been done with the vital station, that, okay, this is where you are, and talking to the patient about where you are in control. And then very importantly, to deal with the complications, to not just think that is only examination, but to say, have I actually asked these questions about your hypertension? And there's some simple questions in hypertension that are important. Patients that might complain about, and that would be, for example, if they have any pain, chest pain on exertion, if they have any swelling of their legs, if they have any orthopnea. These are the kind of things that patients can complain of, that you need to check at that level of history, and then be able to examine for it. And further, same thing with diabetes, to be able to say, are you having any challenge with your vision, or are you having any challenges with your foot? And these are the kinds of things that, or are you having challenges with your sugar up and down? Being able to manage that. So these are important things to think about that I think often with undergraduates I tend to emphasize. Look at those, and of course, as they build their skills up, then they can go to the 5As and 7Cs. So I work in a small practice. Well, actually, it's a big community health center that literally deals with about a fifth of the population of Soweto, of 1.5 million, so about 300,000 people. But within that community health center, I am part of it, but I have set up a practice, what I call a community practice. And the model is basically taking a lot of all of that we talked of and building it into something that tries to look at what can we do to try and manage populations as opposed to managing patients, and look at people-centered care, but in which we can say this is people-centered care, but in which we have person-centered care and patient-centered care. And the model is basically based on, in the African setting, in this setting in Soweto, on being able to empanel patients. And in fact, our population management has been that we've got patients who have people in the streets, that the community health workers that we employed to go out into those streets and actually register them and log them on a sheet that we put up, that these are my patients across these streets, and I have empaneled them. They're now able to use my practice. That space in the community health center, the large community health center, we've got a small building, or 1 out of the 11, and in which we have taken that care in that small clinic and reoriented it to be very much family-centered based, with all the kind of things that we've just talked of, good quality records, an approach that puts patient first, that tries to look at appointments, that tries to look at the way in which we integrate care, communicate with the patient. And in addition to that, look at case management. Now, in this process, other things that we've done is really engage with key stakeholders. And that's the community people, the people that are key stakeholders that we've engaged with. And this has been very important and actually helped us in terms of acceptability in the community, and in fact, protect us against managers who don't seem to like this very much. And all of this has led to information that's been garnered that has, in a collaborative way, allowed us to do targeted health promotion, that have had amazing achievements in that space, where we've achieved costs that are a quarter of the public service in Johannesburg, and being able to improve quality of care tenfold compared to the very community health center that we are sitting in. So I hope that's been good enough to share as ideas and thoughts on what I do and what we do, and how I view primary health care in Africa and the approach to NCDs. I want to just use this opportunity to also flight Afro-PHC. It is our effort as Wonka Africa to be able to say that we cannot, as family doctors, speak alone for UHC, PHC. We've got to do it collaboratively. We've got to overcome our divisions and find ways to do this effectively. And we have developed quite a good consensus around these processes and building on it, that we need strong decentralized systems that are very community oriented, in which payment systems allow us specifically to manage patients where prevention is part of the work that we do and for what we are paid. And this is the kind of process we want to unfold in Africa, a very tall task, considering the very bureaucratized systems in Africa and very poorly managed systems that I've talked of. So thank you all very much. I appreciate the invite. I hope this has been useful, and I'll await any questions or comments. Thank you, Marvin.
All right, thank you, Shabir. I actually enjoyed your presentation very, very much. And right along to our topic this morning, really just to see our brothers and sisters are actually coping with these chronic non-communicable disease, and ideally to discuss models of care that may be appropriate, that we may also learn from, that we may wish to think about here in the Caribbean as well. We're now at the section for question and answers, and so I invite our participants on call, and we have so far at least 444 participants. I'm not sure we're going to get through if all of them have questions, but certainly, are there any major considerations or questions that you would wish, or comments that individuals may wish to make? Certainly, you may do that in the Q&A component, or you could do it in your chat. And so I will pose the first one here, Shabir, from Dr. William Brown. Dr. Brown asks, or comments, is that thanks for the comprehensive presentation, but in your model of clinical information system looks very complicated and costly. Would we need a separate clinical manager for this? How would we implement this in our practice? Would we have to hire an additional staff, an additional clinical manager, a technical IT guy? What's your take on that?
Well, yeah, I think that data is very important. If we're truly to manage care and produce quality, we're going to have to manage data. Of course, that doesn't mean we need complicated systems. As an example, we've got community health workers who go out and I'm going to talk the very low tech stuff, right? There's lots of options to do it very high tech, cheaper and easier. But low tech, community health workers go out and they collect information on patients, where they do a interview, a questionnaire with patients, collecting information. They come back, they actually collate that information into a tick sheet that we created for them. And I'm able to tell from the population, that means not just my patient base, but from the population, just how many diabetics I've got in the 30,000 population that I'm dealing with. And the population I'm dealing with is myself. Well, it's not even myself, it's a doctor with a clinical officer, which is a I don't know whether it's physician assistant, and effectively 2 nurses. And we are able to deal with 30,000 population, but we have utilization rate of less than 1, which is quite low. We see about 80 patients a day, but we've done studies in our community that in fact we are seeing patients appropriately, but they like the service. So the question is that we've been able to achieve this because of the data that we've collected using that simple tool, and then having a simple tool in our record keeping system where we have a family folder, and then we have a community health worker folder where the sheet that they've collected in that family is actually in there. And so the conversation I have with the patient is, oh, okay, Busi has visited you. How is it doing? Is it going all right? She visited you last month. Is the conversation going? I then have a conversation with her, and then I can say, well, you know what, actually, we need to deal with this and that and the other. I save myself the time of lots of education. I then say, let me take that file out. I'm going to tell Busi to come visit you. She's going to do a lot of stuff. They then goes out, and it gets to the community health work. And all along the line, I might have some very basic information I gather, which is within the public service of the number of diabetics I see, hypertensive that I see, and she gets information out there that she collates. Bring that all together, and I actually have very simple information at the end of the month, not requiring any more than myself and community health workers, and time required is relatively low. So you don't need that. But of course, and I think in our settings, we are exploring ways in which we can get an IT-based approach so that patients and community health workers can collect simple information themselves, that we could, in a simple, relatively simple EHR, be able to collect that information and be able to get exactly the same thing done with a lot more of the complexity built up. So you can, of course, go as far as you want in complexity, but information does not mean complexity. You need to make it simple and do it what works for you and make it work for you. And then you'll find the value of collecting more information in better ways.
Sure. Thanks for that. An important consideration is, how does cultural practices, generally speaking, because we inherit a lot of those practices from our ancestors here, where we use a lot of complementary activities, complementary products in terms of our treatment. And the question here is, have you been able to ascertain the impact of cultural practices on compliance and outcomes in your population?
Yeah, I mean, in Africa, there's a considerable use of traditional healing. I think that patients themselves tend to be afraid of judgment by the allopathic system and providers, so they don't tell us. But I think that we've built up a awareness amongst providers of conditions that do conflict with patients. We do try to encourage, as family physicians, a lot of stronger conversation with the patients, that they do reveal that they're using medication otherwise. But we haven't had too many incidents, especially in non-communicable diseases, where traditional healing or traditional medicines have caused problems. It's because more problems in perhaps mismanagement of TB, as well as maternal child outcomes. So those are where the challenges lie. I think if anything in NCDs is perhaps non-compliance, where patients say, you know, culturally they think it expressed in ways that are more cultural and they might defer treatment. So those are the problems we might experience. But I definitely agree that's a problem to consider.
Okay. I have a couple questionnaires on the 5 A's and the 4 C's. So one specific question is really to remind us about the 4 A's. And the second component of that is, how is this integrated for each patient? Is it that it's mainly at your more advanced health centers, or is it used across the health systems?
Well, in terms of the 5 A's of consultation, I think that's what you might be referring to. I've actually talked about 4 C's, but the 5 A's are essentially not a formal system. So, in some settings, like in Australia and other places, perhaps in private practices, you might have that written down, but it's really about what is your process of care. It doesn't need to be done. Now, of course, in Africa, we teach family physicians, and they should be teaching their team. But we are, in a way, a very minority group. We haven't got very much of an impact yet on a broader scale. So this is not being used very widely. But if the family physicians are trained and should be using it, then it's part of our conversation nonetheless. So it's about assessing their behaviors and beliefs. So in other words, it's like motivation interviewing. You understand where they stand, what is their knowledge, and that's part of the exploration. You then understand their, what they know about their risks, as well as their change. So, and that's part of the advice, where you might provide them information, but it in fact should be personalized, and that's the second A. The third A is the question of a collaborative approach, and that's agree, which is collaboratively setting goals. And I think that, again, you want a patient to generate goals and help them to generate those goals, but then build some sort of agreement. Assisting is what we all do, is generally try to support them in different ways, whether it is to solve problems or to look at environmental support or to manage them. It's part of what you do. Arranging is just simply making sure that the patient is managed in the follow-up setting. So it's really about, after they leave you, what are the consequences in terms of their care? So I hope that's clearer. I think at the end of the day, I don't think it's about ticking off the boxes. It's about developing a practice of care, which doesn't take time. It shouldn't be reductionist. It should be, do I think of these issues within a consultation? So it doesn't take time. We don't have it in a formalized way. I mean, a lot of this can become very tick box, and I think that's not the way to go. It's about understanding these concepts and incorporating into a very patient-centered, person-centered conversation that has to manage time, which is all our problems.
Sure. Sam, do we have any poll questions?
No poll questions, but we
All right,
have all the questions set up in the post test.
All right, excellent. Thanks so much. All right, so Shabir, to what extent, so you spoke about the low-tech solution that is present that, we could easily practice in the community. To what extent, certainly within the South African scenario, is this built upon a national health, electronic health record system? Do you have a national health record system?
No. In fact, I think there's a national health, electronic health strategy, And that's the government loves to put up paper. And I think in our country, there's this catfight, I think, about the tender value of such a large project. Fortunately, in our electronic health strategy, they've talked about trying to build in, what's this idea, interoperability as a key concept, which I think is really important, that there should be an architecture of electronic health record systems, but that any system should fit in as long as there's an interoperability in the variety that's systems that are available, and so that they can speak to one another. So there isn't a national one. I think that's a dangerous idea to go for. It's something that the Department of Health is looking at with regards to its the National Health Insurance scheme that is in South Africa. I think South Africa kind of leads the edge somewhat, not entirely, but Kenya and Ghana are the other places where these have come up. But the take-up in these spaces of UHC with the EHR is quite limited, both Kenya and Ghana. And in South Africa, they talk very profoundly about this great system. But when we had the vaccine rollout a few weeks ago, we had to resort to paper to just deal with the fact that they didn't think that there isn't internet connectivity all the time in the spaces that they're thinking of. So that's the kind of tragedy in Africa.
All right, so I'm going to ask a two-part question. So I know this is something that's very dear to your heart as well. The composition of the primary healthcare team. The question here from William, for example, is should we be hiring specific NCD assistants to help us coordinate some of those care? But I know in Africa, we grapple because of the number of doctors and so on. And on this call, we have quite a lot of nurses. Would you wish to comment on what you see for resource-limited environments? What would be the complement of the healthcare team?
I think the complement of the healthcare team is going to be very dependent on the kind of resources in terms of financial resources, political commitment. It can range from doctor to having nurse only managing with the community health worker. The difficulty we have in Africa is that that's the kind of models, very narrow, task shifting, verticalized programs based on very low competency levels. And we feel that we need all of them in one team, but the configuration may vary. So we do need one doctor. We need a complement of nurses, clinical officers, community health workers. The difficulty is that one doctor needs to, together with that team, manage a much larger population than is the norm. And we've talked of in South Africa, and I presented a modeling like that to the National Treasury, that one doctor to 10,000 with a configuration of team would be able to manage quite effectively because of the mix that shows that this can be done, but also because that is the limitation of the numbers of practitioners we have in South Africa. And so that is, again, another consideration when you go into another African country. You can still have the team, but you might say, well, there are not enough doctors, there are actually too few, clinical officers, the nurses. So the team configuration will always shift. But I think that mix of, in other words, saying we don't only need one doctor to look after all patients as privately might be done or might be done in developed countries. We need the entire team. And that team includes, I think, the multidisciplinary team, but importantly, the community health worker being a very generalist community health worker that not only is able to work with us as clinicians, that's the doctor, the nurse, a clinical officer, physician assistant, and to deal with our issues in the community, but also to look at this generalist community health worker was dealing with NCDs and communicable disease and everything else, to be able to also deal with physiotherapists and find ways in which we can bring that physiotherapist close to our practice, but also work with our community health workers so that they can look at extending their reach, teaching community health workers basic rehabilitation techniques that could be done quite simply in the community, that they can teach patients to do and support them in their doing of it. Like that, the dentist and oral health care. So we increasingly in Africa are seeing the community health worker as a important cadre that is part of the team. And that is a generalist trained very much like we would want as a family physician, a generalist with a family medicine orientation, and the same with the team. So I think the question of community health workers, they would need to deal with all conditions. We don't expect them. We'd have to manage the number of patients, number of people they deal with. So we don't want them to deal with 2,000 people. They're going to have to, increasingly as we build up their capacities, have them deal with the less population. So we're looking, at the moment in Shibuya, we have 1,000 to 1 community health worker, but we think that it should be down to 500 for them to really add value better. And in terms of team configuration, as I mentioned, it depends on these variety of factors, what resources we have, depending on the country.
Sure. We have Dr. Aileen Standard-Goulson on the call as well, and she is a chair of a family medicine training program here at the University of the West Indies. Can you just share with us how long does it take to train a family physician in the South African system?
In most parts of Africa, especially in Sub-Saharan Africa, Southern Africa, 4 years.
4 years.
The course basically is usually 18 months in primary care, 18 months in rotations in hospitals, but based on need, and in non-specialist, non-highly specialized hospitals. So it's at regional lower level hospitals. And then it's a year of research and sort of elective.
Okay, great. All right, so I conclude this particular section by addressing a question from Ms. Glasgow. She says that physicians are limited in time to see patients with non-communicable diseases. And now that we're in the COVID-19 era, what should we emphasize and what are the coping mechanisms and systems considering the fact that we now have increased complexity of our patients in terms of appreciation of the complexity between the interaction between the caregiver and the patient. I hope I've done justice to the question, but I seem to get the impression that what she's alluding to is that we had limited time before COVID to interact with our patients who had, and their families who had non-communicable disease. And how does COVID-19 now affects those interactions, in your opinion?
Well, thank you very much. I think that, like I said, we've set up in Shibuya with in South Africa, they've got community health worker programs, and these community health workers function very unlinked, delinked from the clinic, which is the challenge. So in Shibuya, our difference is we're very strongly linked. And what that has done is, as I've showed you with our relationship through record keeping and the relationship we built, have the community health workers work with us very strongly around education compliance of chronic care conditions. So a lot of the problem is that we face actually is that we get a lot of interns or students moving through, and they're very anxious about the care that the patient needs and say, I'll call them back. We've emphasized to them, please do not think that you are somehow going to do care. What do you think is needed for that patient actually? And we've developed we found that through this management, this way of managing a patient appropriately and linking the community health worker has improved the quality of care compared to the clinic, the rest of the health service. What we've also found is that when the COVID came along, we had that system to work with, and we were on the verge, and in fact, the model basically has been developed that can we not get the community health workers to deliver the medicines to patients at home, enhancing the fact that they don't come in. Also that we get nurses who will go doing home visits, who are not us, no nurses who are junior and actually working with the community health workers and support, do home visits on those patients whom we think need a blood taken. So as an example, diabetics, we've turned around and told the clinicians, you don't need to see a diabetic every 3 months. We need to manage the diabetic and see if they are fitting in to our range where they actually either controlled or mildly uncontrolled, and in which we say this patient here, what they really need is we're not going to change their medication. What we need is actually better compliance, and we need them supported in the community. So we said, tell this patient that you're going to get the nurse who's the team leader of the community health workers to do the community health worker to visit every 2 months to deliver the medication. That's simply because of the system demanding 2 months. Otherwise, 3 months would be fine. that they visit and they actually ensure compliance and adherence to medication. They deal with the education. Then that the nurse who visits will be told, please do either a 3, 6, 9-month visit, taking bloods, looking at the HbA1c, and making sure that the patient, through the education about foot complications, eye complications, if they have any, to come back. But the patient only comes back once a year. Now, that is the kind of way we are helping to reduce utilization needlessly, but actually looking at quality of care improvement. And that pattern of behavior has led to our much better outcomes, even though we are seeing the patient less. So time is not a big problem for us. We are actually see patients longer, not because we are somehow special, we've created the situation for ourselves. We've made patients use the system less because we've taken better care of them in the community as well. So I hope that makes sense.
Yes, man. And with that positive note, I'd certainly like to thank you again for your presentation. Certainly, these South-South sharing and collaborations is very useful. Certainly, in the Caribbean, because of our U.S. neighbors, we tend to think north. But clearly, sharing the fact that we share similar environments in many respects and similar problem sets means that certainly we can benefit from greater sharing with our African colleagues. And I do hope this is the start of a great collaborative initiative between the African continent, broadly speaking, and the Caribbean. I would then like to bring this session to a close as we move forward. I just ask you, Shibuya, if you could just stick around and type some of the answers to some of the Q&As that may still be around that I wasn't able to address verbally. And Sam, I think on my agenda, I have a presentation from Mark.
100% true. Let me get the Merck presentation up. And I'll hand over to Dr. Clark.
Good morning, everyone.
Morning, Dr. Clark.
I am here representing Merck this morning to share with you information on their tablet technology that they're using to manage type 2 diabetes, the Metformin. And we can move slides. So we're going to look at the simplified dosing of the drug, the benefits of improved tolerability and adherence with this new tablet technology, and hopefully that will guide you as to why the product is how it is and the benefits it can offer to your patients. So Metformin, as we know, it's in most guidelines, and it has demonstrated benefits in cardiovascular benefits, sustained cardiovascular benefits. It also has really good glycemic control, and in contrast with many blood glucose lowering medications, it is associated also with weight stability, or you may have some amount of weight loss, modest as it may be. We have issues with compliance regarding the product and adherence. So the once daily, you'll realize that there's an improvement in compliance by 79% compared to giving the drug 3 times a day. You have a 38.1% reduction. And so you will find also that because of this, we are not having the condition being managed effectively and appropriately. So polypharmacy is also a major concern with most patients who have type 2 diabetes. They also have other comorbid conditions that causes them to take much more therapies additional to their regular dose for type 2 diabetes. And so the pill count increases, the number of times per day increases. And so you find also that this is a major factor for adherence to therapy. So poor compliance with polypharmacy also increases mortality. And based on the graph by Wu et al., you can see that of the patients receiving therapy, more than 5 chronic medications, you can recognize that compliance issues are increased, and as the years, as the timeline goes. And so we just want to highlight that more people will eventually die also because of that. And so if we can improve the pill counts that we have per day, reduce the amount of the tablet burden on patients, we will find that there's improved adherence and compliance. Move on. So the dosing technology for Glucophage. It's a once-a-day Glucophage XR. It's a required innovative technology that they considered to use when it come on to managing type 2 diabetes. So there is this issue with metformin, is that it is absorbed. When it reaches the bloodstream, it's absorbed through a restricted area of the upper GI tract. And in addition, this absorption of metformin is very saturable. Thus, while it is important that high enough concentrations of metformin are achieved in the area to drive absorption, too high concentrations will saturate the system and lead to some of the metformin missing the absorption window and not being absorbed. So these observations present a challenge in the development of a modified release metformin tablet that would be suitable for once daily dosing. Simply showing release of metformin using standard delayed release technology would not be appropriate, and so would not be, you would find that it would not be absorbed as a once a day tablet, and would have been, the absorption window would have been affected. So what we want, when you look at rapid early drug release, even if we follow a sustained release, it could saturate again this absorption window. And so we needed a new innovative solution. And so what they came up with was this gel shield diffusion system that's patented, that allows for a better kinetic performance of the standard metformin compared to the others. And so if you look at the gel shield diffusion system, it provides more prolonged metformin release, and you will see that it consists of an inner polymer matrix and an outer polymer matrix that does not have the tablet at all. And so this technology allows for the tablet to be delivered, more of the tablet to be delivered, and so you have better absorption, better sustained metformin release of the drug. And so if we look at comparing plasma concentration time profiles, go back one slide, Sam, you will see that the absorption of metformin from the Glucophage XR is slower, smoother, longer, compared with immediate release formulation. As a result, the maximal plasma concentration achieved is slightly lower for the same overall metformin dose. This overall exposure of patient to metformin, the area under the plasma concentration time curve, is comparable between formulations. And so you'll still be getting the appropriate dose that you would be getting. Next slide. So you're getting smoother, more prolonged release compared with the standard metformin tablet, and even hours after ingestion, sorry. Oh my gosh, please forgive me. Once daily dosing, thanks to this gel shield diffusion system, you find that you have flexible dosing options. With metformin, you have it at 500, 750, and 1000 milligrams. And it's definitely once daily dosing. And because of that, you have improved tolerability, improved adherence with the product. And also some of the benefits, when we look at tolerability, the GI side effects were significantly reduced once with this technology came about. And so important to highlight also that in switching and trying to switch from standard metformin to the XR, you have reduced GI events. So if your patient is on the one tablet 3 times a day or one tablet 2 times a day, if you switch to the once daily dosing, you'll recognize that the patients have better tolerability, less GI effects. with that. And when we look at data from both UK, where they did 4 UK-based studies, you can see that GI tolerability is better for the XR once daily. And so it's a good reason for you to consider using a better tolerated therapy. The adherence also, when we compared it, the adherence in a retrospective study, they looked at the XR compared to the regular immediate release metformin, and they also found out that the information regarding adherence was greatly improved, 62% versus an 81% improvement in the study. So what are some messages we want to share with you regarding the metformin is that you want to titrate your patients to a maximal recommended dose, and you want to do this over a 1 to 2 month period. Incremental dose to a maximum of 2,000 milligrams per day. Consider longer acting metformin, such as your XR, which can be given once a day for your patients, and improve the benefits to your patients. The conclusions I want to highlight with metformin is that guidelines do recommend metformin as a foundation treatment for the management of diabetes. And you can see that with the American Diabetes Association, and also with the European Association for the Study of Diabetes. We want to consider that standard metformin has proven glycemic control and has also provided cardiovascular protection to your patients. But what it has highlighted is that there is poor GI tolerability. And with the innovative gel shield diffusion system, you find that you get sustained release from your therapy, and it does allow for once daily dosing. So thanks to this, we also have enhanced tolerability benefits and enhanced adherence through tolerability and improved compliance. This shows that you can also successfully titrate your patients to a maximally effective dose, and additionally that it's now once daily, so adherence to your patients improve their disease outlook, and you find that the increased risk in mortality based on non-compliance will somewhat be alleviated. Thank you for your time. Are there any questions?
Not seeing any questions at the moment. One here from Professor Musa. What is the side effect and cost benefit profile of the gel shield version versus the usual metformin?
The cost profile based on and that's information that I'm not fully cognizant because I'm not in the community setting, but it's very similarly priced from what, when I spoke to the distributors, the prices are very similar. So you're not really, the benefit that the patient is getting way outweighs its mild differences. And I think I will speak to the representative from Merck to highlight that to the clinicians, but there is not much of a difference in the pricing.
Wonderful. And then what is the starting dose?
So normally you start at 500 milligrams and you titrate up within 1 to 2 months up to 2,000 milligrams.
Wonderful. All right. And then there's some kudos in the chat. Persons are saying that they are seeing higher compliance when using glucophage with their patients.
Right. That is definitely, and it is also data. The studies have shown that also. So that is a benefit, that if you can increase tolerability and you can increase adherence, and also the fact that the pill burden is going to be reduced for patients, it is a better way to go in managing patients these days.
Perfect.
Thank you, Dr. Camille Wilson-Clark, for that presentation on behalf of Merck. Colleagues, in the interest of time, we need to move on to session 2. So it's indeed you're welcome. It's indeed my pleasure to pass the baton on to Dr. Aileen Standard-Goulson, who is the chair of our family medicine program here in Jamaica. Dr. Aileen Standard-Goulson, you will take over for now for session 2.
Thank you very much, Professor Reed. It was indeed a
pleasure to hear Professor Mozo's presentation. Very happy that I was able to be here for that. I'm very privileged to be part of this session this morning. In the interest of time, we are going to move on to what I'm sure will be a engaging and interesting session. And it is my pleasure to introduce our first speaker, who is Dr. Jeffrey East, who graduated with honors from the MBBS program of UWI in 1979. His subsequent qualifications include the Doctor of Medicine in Surgery, also from the UWI, Fellowship of the Royal College of Surgeons of Edinburgh, Fellowship of the American College of Surgeons, and Masters in Epidemiology from the London School of Hygiene and Tropical Medicine, University of London. Dr. East has been a consultant in general surgery with the Ministry of Health starting in 1987 at the Savlamar Hospital in Westmoreland, Jamaica, where he was the senior medical officer. He moved on to Cornwall Regional Hospital in Montego Bay as chief of surgery in 1996 and retired from the Ministry of Health and Wellness in 2016. He is a senior lecturer in surgery with the Faculty of Medical Sciences, UWI. Among his peer-reviewed publications, 2 are on the infected diabetic foot, with 1 additional pending, and he is lead author of the Association of Surgeons in Jamaica, UWI Guidance on Management of the Infected Diabetic Foot. He has served on the Medical Council of Jamaica and the Western Regional Health Authority Board of Management, and has been honored by the Medical Association of Jamaica for distinguished service to the medical profession. Dr. East is currently a consultant in general surgery in private practice, senior lecturer in surgery, and deputy dean for the Western Jamaican campus of the UWI, and president of the Association of Surgeons in Jamaica. So I think you will agree with me that Dr. East is eminently suited to present to us on new advances in wound care, in particular in diabetic ulcers. Dr. East, please, over to you.
Thank you, Dr. Wilson. Let me share my screen.
Perfect. Seeing everything.
Great. Okay. Good morning. Good afternoon. Sorry, morning. Good morning, attendees. I've taken the liberty of modifying the topic that was assigned to me so as to keep it in line with the theme of this conference. I will nevertheless be describing the various methods and advances in wound management during the course of this presentation, so we'll remain faithful to the intention of the original topic reflected in your program. First, a general outline of my presentation. A listing of the types of lower limb ulcers that may occur in diabetics is followed by detailed descriptions of diagnosis and management of the 3 most common types, namely venous, arterial, and neuropathic. And the presentation will end with a discussion of wound care principles and practice. Venous, arterial, and neuropathic ulcers constitute 85 to 97% of all lower limb ulcers encountered in diabetics. The rather wide range stated here reflects the fact that prevalence varies by population. I have not been able to identify any research indicating the prevalence of these 3 types of ulcers collectively in diabetic populations in the Caribbean. There is some evidence of the prevalence of foot ulceration among diabetics attending specialist and primary care clinics in Jamaica and Trinidad respectively, but this will be discussed when we get to detailed discussion of neuropathic ulcers. The less common causes of lower limb ulceration are just mentioned here for completion and to remind us that if we have ruled out the 3 common causes, as well as select uncommon causes such as trauma, osteomyelitis, and sickle cell disease, there is a role for dermatology consultation. So we'll start with venous ulceration. There's a lot of speculation about the pathogenesis of venous ulceration, but the question remains unsettled. There is the fibrin cuff theory, in which it is postulated that serum leaks out of the venous end of capillaries as a result of venous hypertension, which is secondary to valvular incompetence, and that this leaked serum forms a fibrin coagulum about the capillaries that interferes with the diffusion of oxygen to the subcutis and skin. And then there is a microvascular leukocyte trapping hypothesis, in which white cells of all types adhere to the endothelium of capillaries and become activated, releasing a host of pro-inflammatory cytokines into the tissues. Regardless of the pathophysiology, what we do know is that once the venous hypertension is corrected, the ulcers heal quite rapidly. There is no research indicating, well, none that I could find, the prevalence of venous ulceration in either the general or diabetic populations of the Caribbean. In North America and some Western European countries, venous ulcers are the most common type of lower limb ulcer in the general and as well as the diabetic population. Note that diabetics have no special predilection for venous ulceration. This is a widely held misconception. Venous ulcers typically occur on either side of the distal leg, about either malleolus, and are usually shallow with irregular flat margins. They are usually associated with visible varicose veins and often with eczematoid skin changes and lipodermatosclerosis. Some dependent edema is common at the end of the day, but subsides after bed rest. Chronic persistent edema is not a feature of venous ulceration unless the underlying venous insufficiency is due to deep venous thrombosis or deep venous obstruction, or recurrent cellulitis and lymphangitis has resulted in secondary lymphedema. So uncomplicated, pure superficial venous incompetence, even with ulceration, is not associated with persistent edema. The workup of venous ulceration is really quite simple. Clearly, a thorough examination of the patient's lower limbs is warranted, including examination of the arterial circulation, since arterial disease may coincide with venous insufficiency. The Trendelenburg test has been largely abandoned. Usually the only imaging investigation necessary is a duplex sonogram of the lower limb veins. This will usually provide all the information needed to support the diagnosis and direct therapy. Duplex venography will pinpoint incompetent valves in the superficial, perforator, and deep veins and identify deep venous obstruction, which is an absolute contraindication to superficial venous ablation. Culture of the wound is not necessary unless there are signs of acute infection, and biopsy is not indicated unless the edges of the ulcer are heaped up and malignancy is suspected. The definitive treatment of venous ulceration due to superficial and perforator insufficiency is ablation of the great and small saphenous veins and ligation or sclerotherapy of perforators affected by valvular incompetence. This addresses the venous hypertension, which is the proximate cause of ulceration, and the ulcers heal rapidly. Graduation compression stockings, by preventing pooling of blood in the superficial veins, also encourage healing of ulcers, actually just as effectively as venous ablation. But stockings are uncomfortable because they apply a significant amount of pressure. Otherwise, they are not effective. They are quite uncomfortable, and patients might find long-term use intolerable. But just to remind, they are as effective as ablation of the incompetent vessels. Wound care is generic and will be addressed later in the presentation. Infection of venous ulcers, even in diabetics, is not usually limb-threatening. Recurrent cellulitis and lymphangitis may lead to chronic lymphedema, and long-standing untreated ulcers may undergo malignant change, what is known as the Marjolin's ulcer. Addressing chronic venous insufficiency in the early symptomatic stages of the evolution of the disease will prevent ulceration and its consequences. Finally, venous ulcers may heal, though slowly, with local wound treatment and frequent bed rest and leg elevation. But those that heal will recur if the underlying venous hypertension is not addressed. Arterial ulceration. This results from end-stage peripheral arterial disease due to atherosclerosis. It does not occur at earlier stages of atherosclerosis, of peripheral arterial disease, only at the end stage. As diabetes is a major risk factor for atherosclerosis, diabetics are at greater than average risk for developing arterial ulceration. However, please note that the pathognomonic microangiopathy of diabetes makes no contribution to the skin ischemia that causes ulceration. End-stage peripheral arterial disease, now preferably called chronic occlusive arterial disease, manifesting as critical limb ischemia, now preferably called chronic limb-threatening ischemia, is logically going to affect most severely the tissues furthest downstream from the heart. It is not surprising, therefore, that arterial ulceration affects predominantly the tips of the toes and the dorsum of the foot. You will see it stated in textbooks and the journal literature that arterial ulcers may occur about the malleoli. Although that is true, as seen in the picture on the right, arterial ulcers never occur in the distal leg without simultaneous critical ischemic changes in the ipsilateral foot. At least I have never seen it. And even if you look at the pictures in the literature, the foot is never normal. And giving the impression that arterial ulcers may occur in isolation about the ankle without observing that the adjacent foot is not normal can be misleading, in that it gives the impression that they may mimic venous ulcers. They do not. The distal foot is always affected when as we can see in the diagram on the right, when patients have perimalleolar ischemic ulcers. The ulcers are usually shallow with a punched out look, regular flat margins, and often a gangrenous base. Critical limb ischemia with arterial ulceration is often the first manifestation of peripheral arterial disease in diabetics. Diabetics often do not experience pain during what would be the claudication phase in the evolution of PAD, peripheral arterial disease, in a non-diabetic, because their lower limbs are often insensate from peripheral neuropathy. Just to reiterate what I just said, diabetics often do not pass through that claudication phase, which in non-diabetics will warn you that they have significant peripheral arterial disease, which, if not interrupted, will eventually become end-stage disease. The workup begins with a physical examination. The anchobrachial index should be measured routinely in patients in whom you suspect arterial ulceration. Although a Doppler machine makes it easier to identify weak pulses in the foot, ankle and systolic foot pressure, which constitutes the numerator in the anchobrachial index, may be reasonably accurately measured in the office using an automatic blood pressure machine. So it is something you can do in your daily practice. Arterial ulceration is usually associated with an anchobrachial index of less than 0.45. The next imperative after measurement of ABI is to determine whether the architecture of the obstructing lesion makes revascularization feasible. Current standard of care requires that a non-invasive arteriogram, a duplex, a CT, or MRI angiogram be performed. Duplex angiography is safer in patients with significant renal impairment who may suffer deterioration in renal function from the contrast required for CT angiogram and MR and magnetic resonance angiography. Angiographic features indicative of lesion architecture amenable to surgical bypass or endovascular intervention are: 1, good inflow of blood in the part of the artery proximal to the obstruction, sufficient to provide perfusion through a bypass graft or stent to the distal limb. 2, a relatively short obstructing lesion, particularly if stenting is to be considered. And 3, the presence of a patent functional vessel distal to the obstruction to receive blood from the distal end of a bypass graft or stent for distribution to the ischemic foot. Poor inflow may be improved, but a long obstructing segment and absence of a patent runoff vessel makes revascularization likely to fail, if not impossible. So in the diagram in this slide, the architecture on the left offers good prospects for successful bypass grafting. There's a good running vessel. There is a well-constituted runoff vessel, which allows for the anastomosis to a bypass graft. And the segment of obstruction is not excessively long. The problem with long segments of obstruction is that the bypass grafts are too long and they invariably become occluded. However, the architecture in the middle, there's no runoff at all. There's no vessel there to plug your bypass graft into. This one is not amenable to revascularization at all. Patients with diabetes face particularly difficult lesion architecture, as atherosclerosis in diabetics tends to affect predominantly that part of the lower limb arterial tree that is distal to the knee, where the small vessels involved make vascular bypass much more likely to fail in diabetics than in non-diabetics, where involvement of larger arteries predominates. If lesion architecture is not amenable to revascularization, diabetics are facing the prospect of a major amputation below the knee and possibly higher. The toe amputations that will control a foot infection in a non-ischemic diabetic foot will not be sufficient treatment for critical limb ischemia. If you amputate two obviously gangrenous toes in a patient with critical limb ischemia, the rest of the foot will just go gangrenous. There's not sufficient blood supply to support the healing of that wound. Understanding this difference between management of the infected and ischemic diabetic foot is critical if inappropriate treatment is to be avoided. For the same reason, wound care in these patients in the absence of revascularization is likely to be unhelpful. Finally, remember that atherosclerosis is a systemic disease, and critical limb ischemia is always associated with significant cardiac and cerebral arterial disease, always. Indeed, involvement of these two organs constitute a much greater threat to life than limb ischemia and must be evaluated and treated. Good glucose control may reduce but not eliminate the risk of progression of atherosclerosis in diabetics. Once peripheral arterial disease is diagnosed, statins should be prescribed, even in diabetics with normal lipid levels, as these drugs have an anti-atherosclerosis effect. It is referred to as a pleiotropic effect, a sort of anti-plaque, anti-inflammatory effect, which is separate from their cholesterol-lowering effect. In addition, the patient should be started on a supervised and limited exercise program. Supervised because over-enthusiastic exercise may increase the risk of neuropathic ulcers, which we are going to discuss soon. What is the prognosis? Unfortunately, with the best efforts, 50 to 60% of patients diagnosed with critical limb ischemia will die within 5 years of the diagnosis, most often from myocardial infarction or stroke. And we now move on to discussion of neuropathic ulcer. Of the common and even uncommon types of lower limb ulcers that may occur in diabetics, the chronic neuropathic ulcer is the only type that is entirely attributable to diabetes and its complication, peripheral neuropathy. This is the type of ulcer referred to in the unqualified expression, diabetic foot ulcer. Neuropathic ulceration results from repetitive, excessive pressure to the skin over pressure-bearing areas of the plantar surface of the insensate foot of diabetics who have peripheral somatic neuropathy. Even the normal activity of standing over time will precipitate the localized subcritical ischemia of pressure-bearing points that ultimately leads to breakdown of the overlying skin. Patients with insensate feet will hold a fixed standing position for excessively long periods because the subconscious pain signals that tell us we need to shift our position to relieve and redistribute the pressure of standing on our feet aren't getting through. Although the autonomic neuropathy of diabetes contributes to the risk of neuropathic ulceration, it is the somatic neuropathy that is the main culprit. There are hints, but not definitive evidence of the prevalence of chronic neuropathic ulcers from 2 clinic-based studies in the Caribbean. Ferguson et al. Identified a prevalence of foot ulcers of 4.3% among patients in a specialist diabetic clinic at the University Hospital. Whereas in Trinidad, Gulliford and Mahabir found that 12% of diabetics in a primary care-based sample had similar foot ulcers. There is no prevalence data that I could find for the general diabetic population in any Caribbean country. The international literature suggests that as much as 35% of diabetics will develop chronic foot ulcers. Most, if not all, diabetics will eventually develop peripheral sensory neuropathy, And although good diabetes control reduces the risk, it does not eliminate it. Therefore, even well-controlled diabetics are at risk for neuropathic ulceration. Neuropathic ulcers usually occur on the pressure-bearing parts of the plantar surface of the feet, particularly the forefoot, but may occur at points on the dorsum of the toes and feet from ill-fitting footwear. Workup includes a thorough examination of both limbs with testing for peripheral neuropathy and evaluation of the arterial circulation. X-rays should be done routinely to identify underlying osteomyelitis and the bony destruction that accompanies charcoal foot, both of which conditions require orthopedic consultation. Culture of ulcers is not necessary unless there are clinical signs of infection, such as erythema extending significantly beyond the ulcer margin, exudate, and increased warmth. If infection is present, tissue should be sent for culture rather than exudate, as the latter is likely to yield contaminants rather than the main organism causing an infection. One of the major obstacles to good diabetic foot care in Jamaica is the paucity of podiatrists in our health system. As far as I'm aware, there are no podiatrists in the public health sector and never have been. We need to lobby for establishment of posts for podiatrists in our public hospital clinics and health centers. The vast majority of diabetics who cannot afford private care in Jamaica get almost no specialized foot care at all. This role cannot be fulfilled by any of the medical generalists and specialists listed in this slide because we are not trained in the specialty of podiatry and specific foot care. Although wound management is important in preventing neuropathic ulcers from becoming infected, these ulcers will not heal with wound care alone. The pressure on ulcerated areas must be offloaded if healing is to occur, and indeed must continue, that's the offloading, must continue after healing to prevent recurrence. The total contact cast shown in the pictures in this slide, the picture on the left, is the offloading device that has been most successful in getting neuropathic ulcers to heal. If there is patient resistance to the application of a plaster of Paris or fiberglass cast, the walking cast shown on the right may be used instead, but patients must be advised to wear the device at all times when they are out of bed. If they get into the habit of removing the device, even occasionally when upright, it will not work. Both of these orthotic devices work by redistributing the pressure applied during walking and standing from points on the sole of the foot to the entire area of skin contact of the device. Once the ulcer has healed, patients should be referred to an orthotic service to be fitted with customized footwear. Digital pressure analysis devices are now available and will allow design of footwear to redistribute the pressure of walking and standing to the whole surface of contact of the shoe. Unfortunately, the most consequential complication of neuropathic ulceration is that they eventually become infected and lead to amputation. Again, unfortunately, this is the natural history of neuropathic ulceration in Jamaica, I am afraid to say. Offloading as a critical component of the management of these patients has not caught on to any significant extent, certainly not in the public health sector, but neither to the extent that it should be a routine part of the care of these patients in the private sector. I hope that this is changing. So how do we prevent neuropathic ulceration in our diabetic population? Improving diabetes control is important, but I am sure our general practitioners and internists are already doing their best. Qualitative research is needed to identify myths, beliefs, and behaviors in our population that are deleterious to compliance and self-care practices that targeted education campaigns will need to address. The diabetic foot should become no less a focus of routine care than glycemic control, and development of a network of practitioners dedicated to foot care, such as podiatrists and orthotic specialists, must be encouraged. I will now do a brief summary of wound management. First, the principles. As listed in this slide, the first principle is removal of necrotic tissue and debris. Wounds will not progress from the inflammatory to the proliferative phase of wound healing until all necrotic tissue and slough has been removed. Wound healing requires a moist, warm environment. The tissues will necrose if they become desiccated, hence the second principle. But the wound must not be so wet that it becomes macerated, hence the third principle, absorption of excessive exudate. Bacterial load must be controlled so as to prevent progression to sepsis, and exogenous contamination must be prevented, hence the fourth principle. And finally, any adjuvant therapies that stimulate proliferation of healing tissues should accelerate wound healing. So in practice, what do we do? Wound culture is not necessary unless there are clinical signs of infection, which were discussed previously. If infection ensues, remember that tissue rather than exudate should be sent for culture. You may do a biopsy of the wound, preferably, rather than scraping the surface of the wound for culture. Systemic antibiotics need to be administered only if infection ensues. They have no role in the management of a non-infected ulcer. The scalpel should be used to cut away gross necrotic tissue, but this often leaves a tenuous necrotic patina that we call slough that cannot be grasped with forceps. This is best removed gradually with the debriding agents or dressings listed in this slide, including, I'll just briefly go through them. There's the tried and true wet to dry dressings, where you place a wet gauze dressing on the wound, allow it to dry, it will stick to the slough, and you pull it off along with the adherent slough. Chemical agents such as hydrogen peroxide, povidone iodine, and Edinburgh University solution will also eat up slough. Enzymatic debriding agents such as raw papaya, preferably the fruit that is just about to become ripe, what Jamaicans call turn papaya. That is the best stage at which to use the raw papaya. Or you may use Accuzyme, which is an isolate of the papaze enzyme in a cream format. Maggots are still used, and they are available. The larvae are available in proprietary packets. We are now going to be discussing dressing types and how they support wound healing. I've already introduced desloughing dressings in the previous slide and will not elaborate any further. Suffice it to say that debriding dressings should only be used until wounds are free of slough. That is, during the inflammatory or cleanup phase of wound healing. They should be discontinued as soon as the wound is clean, otherwise they retard re-epithelialization and granulation tissue formation as the wound enters the proliferative phase of healing. These debriding chemicals will eat up your neoepithelium and your granulation tissue just as enthusiastically as they eat up slough. This slide pretty much speaks for itself. Just to add that there really is no solid research evidence that any of these dressings achieve significantly superior healing compared to each other, except maybe for gauze dressings being potentially problematic. If the gauze is allowed to dry out on the wound, it will stick on to as we explained previously, it will stick on to not only to the slough, but to the proliferating tissues and rip them from the wound as well. Biologic dressings are at least less troublesome than the others, as they may be left in place until they are rejected by the healing wound. This slide also speaks for itself. Just to say that negative pressure wound therapy is probably the most effective of this list of dressings, and it will be described in just one slide later on. This slide also speaks for itself. The only thing I want to add is that antibiotic creams are ineffective in reducing bacterial load and may encourage emergence of resistant organisms. Topical antibiotic creams should be avoided. And here I would like to point out that topical growth factor preparations like Regranox and Becalpermin, which are formulations of platelet-derived growth factor, although they are proven to encourage wound healing during the proliferative phase, have largely been abandoned because of an association with increased non-specific cancer diagnosis after more than 3 tubes have been used. No mechanism has been postulated for this association, but I suppose we could probably imagine a plausible explanation. Heberprot P, which is a Cuban product, a solution of epidermal growth factor, which is injected. It holds promise, but has not been proven effective and safe in independent trials, in trials outside of Cuba. And maybe I've seen one trial out of Mexico. And finally, I would like to mention this novel dressing type, which is called Microdesign. It's a relatively new product on the market in which superoxidized water is used as both a cleaning agent and dressing. I have personally had good results with this product, but I don't want to push anecdotal evidence too far. Suffice it to say that there's a paucity of supporting research evidence. But I must admit that I've been impressed with the results. I'm really anxious to see some research evidence supporting its use. And penultimately, a word on negative pressure wound therapy. This is proven in randomized controlled trials to speed healing of open wounds. It's one of the few modalities that really achieve this compared to traditional gauze dressing. It is most effective after wounds are cleared of necrotic tissue. How does negative pressure wound therapy work? It induces shrinkage, encourages shrinkage and contraction of the wound. It microdeforms the wound surface, and this stimulates fibroblast proliferation and angiogenesis. It efficiently removes exudate and edema fluid. which controls both bacterial burden and improves wound perfusion. And it maintains moist wound environment and effectively prevents exogenous contamination of the wound. So this interesting dressing modality addresses all of the 5 principles that we mentioned before for wound care. And finally, if all else fails to achieve complete healing, including treatment of the underlying disease, the plastic surgeon should be consulted so they can employ their grafts and flaps. Thank you very much. That ends my presentation.
Thank you very much, Dr. East, for a very interesting presentation. I am sure there will be questions that will be generated from it. I remind the participants, please put your questions in the question and answer section that you will see the icon below Q&A. If you put your questions there, we will get to them when we are in the question and answer section. In the interest of time, I am going to thank Dr. East and move right on into our next presentation. The questions will be taken after. It's my pleasure to introduce Dr. Soibo. Yes, I think that the presentation comes first with Dr. Soibo.
No, it actually, we have a presentation from our sponsor, Sanfer.
We're going to have our sponsor first? Fine.
Yes.
So our sponsor is Sanford, and Janice Doheny is going to be presenting, and then we will follow with Dr. Soibo. Mr. Haney.
Hi, Janice, you're muted. Can you unmute for me? Let me help you out here. Let's stop that. All right, so let's get you unmuted first. Great.
Yeah. Okay.
Perfect, and I'm seeing you.
Good morning, everyone. I'm Janice Duhaney. I'm the sales manager for Sanfer, a Mexican company out of, I have responsibility for the North Caribbean. And today we're going to take a look at a very interesting product called Microdesign 60. Are you seeing my screen?
Yes.
I'm trying to enlarge it. Okay. All right. Long before COVID-19, I'm going to tell you give you a little background about Microdesign 60. Tall tales and truths of the legendary past. What happened is, about 30 years ago, if those of you who are old enough to remember the USSR and the Cold War, the scientists in the Eastern European countries were busy making superoxidized solutions because they thought the next warfare was going to be a germ warfare. And so they developed superoxidized solutions because it was proven that the antimicrobial spectrum is excellent. But what they found is that the first set that they developed had a pH of, had an acidic pH, and therefore was very unstable. And the shelf life was very short. So while the spectrum of activity was quite impressive, it was very short-lived. And so they tweaked it and made alkaline superoxidized solutions, which did not necessarily have as good antimicrobial properties. And again, you know, the longevity wasn't there. So they researched and realized that the ideal would be to make one that had neutral pH, which would offer tissue compatibility. And so Microdesign was developed.
Because it's not a PowerPoint, you might have to scroll down.
Okay. Okay, so it's called Microdesign 60 because in 60 seconds, it eradicates these microorganisms, viruses, bacteria, and fungi. No, because Microdesign 60 is a very simple product. It's a combination of purified water and sodium chloride. But what happens is through an electrochemical reaction, you get the formation of hypochlorous acid, sodium hypochloride, hydrogen peroxide, chlorine gas, and some ozone. And these reactive species are in such small concentrations to not be cytotoxic or deleterious to the tissue. So Microdesign offers excellent antimicrobial spectrum. Viruses, bacteria, fungi in 60 seconds, spores in 15 minutes. Now, because Microdesign is not an antibiotic, you will not have bacterial resistance. So even organisms like methicillin-resistant staph, vancomycin resistant enterococcus, there's no bacterial resistance. Microdesign eradicates Mycobacterium tuberculosis in 5 minutes. So Microdesign is a powerful antiseptic product. It's a superoxidized solution, as I mentioned before, and has excellent impact on all kinds of wounds, whether it's a surgical wound or infected wounds, wounds such as diabetic foot ulcers, necrotizing fasciitis, diabetic osteomyelitis, and so on. The impact is quite impressive. So it comes as a spray, right? So a bottle with an atomizer, comes as a hydrogel, and I'll just demonstrate to you. It's a gel formulation, non-toxic, non-cytotoxic, and Microdesign also comes as an oropharynx. And the oropharynx is particularly useful these days with the presence of COVID-19. So any patient that may present with a mouth ulcer or a sore throat or any activity, infective activity in occurring in the mouth, then Microdesign is indicated. So Microdesign is proven to impact the healing time of the wound. The hydrogel is particularly useful because it maintains the moisture, and Dr. East mentioned in wound management that the level of moisture is very important. So it shouldn't be weepy, but sufficient to maintain the integrity of the wound. Microdesign facilitates the whole granulation process and so on. And what happens is it can be used, Microdesign can be used to irrigate, right? It can also be used to facilitate the debridement as well. So it helps with the desloughing. And because it's non-cytotoxic, it doesn't have any damaging effect on the wound. Microdesign is non-irritating. It's tasteless, it's odorless. It doesn't cause any burning and stinging at the site of application. So it's indeed very well tolerated. So how do you use Microdesign? Wash the area, right? And you can apply the Microdesign spray. You can dab the area with a dry compress, and then you can also be generous with regards to the hydrogel, or if you're using the spray, again, you can implement that as well. But 60 seconds is a rule of thumb. So in 60 seconds, viruses, bacteria, and fungi are eliminated. If you want it to be in the instance of disinfection and you're thinking of maybe your equipment, then you need to expose the implement or tool to at least 15 minutes, and at that point you will get sterility occurring. So as I mentioned before, there are 3 presentations. The hydrogel, which is relatively new, that was introduced around April last year, and the oropharynx as well. The microdacin spray has been available in Jamaica from about 2015. In the initial stages, we had introduced our 5-liter presentation, which was used to sterilize equipment. And so we had a little issue in those early days because the shelf life was a little bit short. So by the time you would warehouse, the active shelf life was a little bit limited. And so we discontinued that presentation, but we're hoping this year to be able to offer it to our clients. Useful, and they're using it quite extensively in Central America and Mexico to irrigate intra-abdominal irrigation in septic kinds of situations where it's necessary. And they've had extremely good success in that area. So the microdacin, as I said, 60 seconds, called microdacin 60, comes as a solution, hydrogel, and oral rinse. But just one quick mention, microdacin works by affecting the protein in the wall of the organism. It impacts the protein, and then what happens is the vital functions are affected, and then you get osmotic shock lysis and cell death. And because of that mechanism of action, you're not going to be setting the patient up for bacterial resistance because the mechanism of action is not as an antibiotic. So it's a superoxidized solution, proven efficacy in all kinds of wound care, whether it's a clean wound, a surgical wound, or a contaminated wound. Microdacin is indicated. Locally, the indications have been quite broad and varied. Microdacin has been used in simple wounds, as in episiotomies, in instances where you have cracked nipples and so on, can be used there. With the advent of COVID, again, quite well suited for that kind of situation because it's virucidal, bactericidal, and fungicidal. So microdacin is an antiseptic, a superoxidized solution with proven efficacy. There's no bacterial resistance. Microdacin does not affect the vascularity of the granulation tissue, and that is very important to note. So whilst the wound healing is taking place, granulation occurs, you don't have to worry about any negative impact that microdacin will have on the whole wound healing process. And as I mentioned before, the efficacy is there against all kinds of microorganisms, and there's no bacterial resistance. So microdacin is a good option in wound care. Powerful antiseptic, which facilitates wound healing. It's non-corrosive, non-irritating. It's fine on all kinds of tissue. It's fine on the mucosa. And because of its pH neutral state, it does not cause any irritation. No need for dilution. Microdacin is ready to use and should be part of your regime when you consider any form of wound care, or if there's need for disinfection. Microdacin is very, very indicated for that. So I'm going to just wrap up. I'd like to thank the CCFP for allowing me this opportunity to do this presentation, and I am going to segue into just a short video so you'll be able to get a quick overview of microdacin.
We're not seeing your video.
We need to screen share.
All right, yes.
Yeah, but I think we're also over time for this section. So unfortunately, I think we'll have to just move on to the next presenter.
All right, I want to thank Mr. Haney very much for her presentation. I know you may have a few questions for her. I would ask you to put them in the Q&A section and ask Mr. Haney please to answer to type in the answers to these questions in the Q&A. So moving right along, that was a very timely reminder right after Dr. East's excellent presentation. We move on now to our second and final speaker in this section, Dr. Adedomola Sohibo. It's my pleasure to introduce him to you. He started his tertiary academic career, gaining a Bachelor of Science in Biochemistry and Chemistry, followed that with a MBBS, a DM in Internal Medicine, and a clinical fellowship in nephrology, all from the University of the West Indies. He has done a number of postgraduate training and experiences in the area of nephrology in North, South, and Latin America, and also in Europe. His current appointments at an academic level, he is senior lecturer in the Department of Medicine since August 2015, coordinator of the Doctor of Medicine program UWI-MONA since 2016. He is a consultant nephrologist and internist in the Department of Medicine since 2009, and assistant editor in the West Indian Medical Journal since 2011. He is also chair and founder of SYARC Research Institute, technical director of the Caribbean Institute of Nephrology since 2008, assistant chief coordinator of the annual conference of nephrology and hypertension, chief coordinator of the Jamaica Renal Week Symposium. He has done a number of consultancies, presentations, and has a number of peer-reviewed publications in the area of nephrology. As such, I do believe that Dr. Sohibo is well placed to share with us his thoughts on diabetic nephropathy, how to prevent, very important, when to refer, and how to monitor your patients. So Dr. Sohibo, it gives me great pleasure in welcoming you and asking you to go ahead and share your screen and your presentation with us.
Thank you and good morning, everyone. Let me just thank Dr. Standard Goldson for that elaborate introduction. And I must thank the organizers and the president for this kind invitation for me to share my thoughts on the diabetic nephropathy. I'm going to try and stick to the timeline that is given. So, do not have any relevant disclosures pertaining to this presentation. But if we were to ask ourselves, and just like a quick thing, what proportion of persons with diabetes do have blood pressure control target? I chose to use 130/80 in this meta-analysis. That was this data from Venous between 2003 and 2006, looking at blood pressure target, LDL goal less than 1.8 and HbA1c less than 7. And you'll be surprised to find out 31% were at target for blood pressure, and LDL 28%, and HbA1c was at 26%. So which means there's still a lot of room left for diabetic and management of their complication. But I don't think this is too far from home. So I will share some information on what's been happening in Jamaica. So as Dr. Goldson had mentioned, my presentation is not necessarily driven by these headings, but certainly is what I intend to do in the different aspects to look at how we prevent diabetic nephropathy. When should we refer? And that is just mostly dependent on the confidence of the managing physician. And then how do you monitor this presentation now? So how do you prevent diabetic kidney disease? So I think the first thing in terms of preventing is looking at what the information we have out there is telling us about diabetes. And not just in Jamaica, although I'm presenting data on Jamaica, but if you look across the Caribbean, you're gonna find the similar information in terms of the prevalence of diabetes is rising. We're at 8% in 2007-2008 survey, with only less than half of them at target. And then moving on to 2016, we're now at 11.9%, with even a smaller percentage at target of 27.5. And for the more recent look at what's happening in kidney disease, we know that diabetes and hypertension still remains the two most common cause of chronic kidney disease in Jamaica. And the distribution in terms of male to male-female ratio is also reflective of what's happening with the general population. So we looked at some of the patients that we have at the University Hospital where I currently work, and our diabetes clinic is going to be skewed because we see persons with diabetes and the different complication. And the aim was really to look at the estimate of prevalence, to estimate the prevalence of CKD for those persons who are attending this specialized clinic. And for the purpose of that study, we define CKD as reduced GFR, or when they have albumin creatinine ratio greater than 30. Otherwise, what we used to refer to as microalbuminuria. And also importantly, to look at the risk adverse outcome in terms of categories, and we use the KDIGO 2012 prognostic grade. And if you look at the characteristics, this is again reflective of the general population. BMI was higher in female compared to male. HbA1c, funny enough, is more controlled in male compared to women, although women seem to have more healthcare seeking behavior. That maybe none of the authors in the group might be able to explain why that difference is. But suffice to say, though, when you look at the prevalence of reduced GFR, we're looking at average prevalence of about 22. And when we look at the presence of albuminuria, we're seeing a higher prevalence of 62.1% of diabetic kidney disease. And if you put everything together, then we're looking at the overall prevalence of 86.3 for diabetes. So which means more than 3 in 4 diabetic patients that comes to our clinic will have evidence of diabetic kidney disease. Now, this is what the grid looks like. And basically, the grid gives you sort of an idea of risk factors. Anything is green is good, and clearly anything yellow, orange, and once it starts to get red, tells you that you have a high risk of cardiovascular disease. Just a quick summary that if you have albumin creatinine ratio of less than 30 and your GFR is above 60, then those are the persons with the least amount of risk factor for cardiovascular disease. But once there's presence of proteinuria,
whether in the micro, as we used to use the term before, or the macroalbuminuria range, then your risk increases exponentially. And so we have to now treat persons with diabetes and proteinuria according to this risk stratification. This is just, a list from the American Diabetes Association that tells you what's the mechanism or things that will contribute to diabetic nephropathy. Hyperglycemia, clearly, then we look at systemic hypertension. What's happening with the kidney? There's going to be genetic predisposition, the presence of proteinuria, advanced glycosylated end products, and the activation of local renin-angiotensin system within the kidney. And do not forget that lipids abnormality will also contribute to this problem. So let's dive a little bit more into the function of the normal kidney. So the panel A shows you what happens between when you have the afferent arteriole with blood flow on the inside, and then this is the efferent arteriole where blood leaves. And within the glomerulus, there's going to be a pressure gradient, and that is what facilitates glomerular filtration. And most of the stuff that are filtered, the ones that need to be reabsorbed are going to be reabsorbed in the proximal tubules. Now, when you look at panel B in a diabetic patient where you have vasodilatation, which can be contributed to by prostaglandin, which are locally produced, and you're going to have vasoconstrictors, so catecholamine release. Now, this is going to lead to a net effect of high glomerular pressure, and that is going to increase the glomerular filtration pressure. And of course, this has other effect with increased reabsorption in the tubules and the descending tubules. And also this has a negative feedback effect because of reduced delivery of solute to the macular denser cells. Here, you're gonna have initiation of local renin-angiotensin within the kidney, and that will lead to vasoconstriction. So the net effect is to increase intraglomerular pressure. Now, whereas all of this can be considered an adaptive response in the initial stages, it becomes progressively maladaptive, and then you're going to have progressive loss of nephron mass. Now, what is happening here is what happens locally within each nephron, and the idea is to maintain glomerular filtration. So the total glomerular filtration is maintained, but individual filtration within each nephron is increased. So just to give you sort of like an overview, so at the time of diagnosis of diabetes, whatever time that is for type 2 diabetes, you're gonna have hyperglycemia taking place with your GFR being high, and this is the stage of hyperfiltration. As time goes on, over years, you're gonna have development of cellular injury within the nephron. You're gonna have mesangial expansion, then that's gonna lead to glomerulosclerosis, tubular interstitial fibrosis, and all of this now will manifest clinically as a patient presenting with microalbuminuria that progress to macro and overt albuminuria. Then when you look at the GFR that starts off initially high, which is hyperfiltration, GFR returns to normal, then you're going to have a reduced GFR, and then you're going to get to a stage where they will require renal replacement therapy. Now, in any glomerular disease or any kidney disease, if it is not due to hypertension develops as the GFR falls. I think I have another slide that shows us at what stage that we're going to see hypertension developing. Now, if hypertension is the primary cause, then you'll find that hypertension becomes even more difficult to control, or you're going to require more medication. And then we have development of cardiovascular disease, and then the complications that we will talk about later on when we speak of CKD specific complications. So this is just a schematic diagram, just trying to understand what is the relationship between advanced glycosylated end product and the formation and what leads to glomerular basement membrane. So you're gonna have hyperglycemia with free amino acid groups of protein that are freely moving within the cells. This is a non-enzymatic modification, and you're gonna have glycation of these free amino acids. And then these amino acids that are now being filtered are going to lead to cross-linking and the damage to the glomerular basement membrane and other vascular particles that are present within the kidney. And of course, this now leads to also functional changes. Now, if you look at hyperglycemia in by itself, whether it's type 1 diabetic or type 2 diabetic, this has been associated with a reduced appearance of diabetic nephropathy. So, which is, if you control the glucose, then there's less evidence for microalbuminuria, and everybody will be familiar with the landmark trial of DCCT, which was looking at glucose complication related to diabetes in type 1 diabetics. Now, if you look at the hyperglycemic states, now that sensitizes in some way the endothelium to injury from high blood pressure. So the kidney in itself becomes more sensitive to changes in systemic blood pressure. And in another study that was done in type 2 diabetes, what they actually found was that when there's an insufficient decline in nighttime blood pressure, the so-called non-dippers, that hyperglycemia and in a state of non-dippers, there seems to be an early onset of microalbuminuria. Now, if you were to successfully transplant these persons, what you find is you have a reversal in diabetic nephropathy. Now, what about proteinuria in itself? So before we know that proteinuria is a marker of kidney injury, but we also know now that proteinuria or albuminuria is a marker of progressive renal injury, because once you have increased proteinuria, that means we have a glomerular basement membrane that the size selectivity theory, if you guys remember those days of medical school in terms of size and charge selectors, that once you have an increase in permeability of glomerular basement membrane, then you're going to have leakage of protein. And these proteins, once they are present, due to the work of the proximal tubular cells trying to reabsorb by method of ingestion, the presence of this protein now leads to initiation of inflammatory response within the tubular cells. And of course, this leads to death and interstitial scarring. Once there's interstitial scarring and there's death of that glomerulus, the neighbor and all the other relatively functioning glomerulus will now have to undergo further hypertrophy and hyperfiltration to maintain a total GFR for the patient. And then they have the initiation of the local renin-angiotensin, as I mentioned, and this will lead to proximal tubular epithelial cells and mesangial and podocytes. So all of these are involved in the local renin-angiotensin system activation in diabetic patient. Now, it's not all just what I just described, the hyperglycemia, the proteinuria, the blood pressure, but there are also other risk factors that you need to consider. So older age, male gender tend to have, importantly, family history. We need to ask about family history of a diabetic mother or father with development of kidney disease. And then we have genetic diseases that also will predispose you to diabetes. Because remember, diabetes can have kidney disease that is outside of their regular, outside of diabetic complication. Now, also the other thing we need to consider is acute kidney injury, in terms of toxins and patients who smoke. All of these are risk factors for development and or certainly for progression of kidney disease. And then we need to look at the dietary protein factors, how much protein intake the person is engaged in, apart from just in terms of calories, but also in terms of toxicity to the kidney system. So let's just summarize that aspect in terms of diabetic kidney. So in people who have diabetes, we have to remember that an increase in albumin and a decline in GFR can be due to classic diabetic glomerulopathy, but we have to understand that reduced GFR without albumin is being recognized, and this may suggest that there might be underlying mechanisms. So initially, we used to speak of looking for albuminuria before you can make a diagnosis of diabetic kidney disease. But we now know that you can have reduced GFR without albuminuria in a quarter of persons who have diabetic nephropathy, and that is the root cause of their diabetic kidney disease. Also, we need to remember that people with diabetes can develop kidney disease for other reasons than just diabetes, and that's where the whole idea of when to refer is going to now come in. So before you refer the person, then you must have at least done some kind of clinical diagnosis of the person. So how do we make a clinical diagnosis of diabetic kidney disease? We still use measurement of eGFR using the GFR calculator. And also, we also look at albuminuria. And we have to look for clinical features of diabetic microvascular complication. That hasn't changed, and we need to monitor that. But I will also add that we need to look at the urine microscopy and urine analysis because that could be a clue to a non-diabetic kidney disease in a patient that has diabetes and albuminuria or reduced GFR, because typically we do not expect to find any evidence of active urinary sediment or red cell cast, hematuria in a diabetic patient. Of course, we have to make sure that we now try and eliminate confounding factors, urinary tract infections, stones, other disease that can mimic diabetes, and even sometimes a diabetic with uncontrolled hypertension may have urinary microscopy that is abnormal. That's not necessarily due to diabetes. Now, we can now define that this person has diabetic kidney disease clinically when this urine albumin creatinine ratio is persistently elevated, or if you have a persistently sustained reduction in glomerular filtration rate. And typically we look at persistence of these things for more than 3 months. We know about the screening guideline that hasn't changed in diabetic person, type 1, or in a type 2 diabetic patient. Now, we need to consider other causes of albuminuria in this patient. So probably when you see or don't see this, you have to consider maybe this person needs to be referred. If they have absence of diabetic retinopathy, now a lot of us might not be in that position to perform a fundoscopic examination, but you can also refer this patient to the ophthalmologist to get a full examination to determine whether they have other evidences of microvascular complication. Now, if you see a diabetic with a low or rapidly decreasing GFR at the inception of diagnosis, then that's probably could clue you in as to whether this is really diabetic nephropathy. If you see a reduction of greater than 30% in GFR after initiation of RAS blockade, either using ACE or ARB, then you need to probably consider. I mentioned this earlier on, the presence of active urinary sediment, refractory hypertension. Now, hypertension, I mentioned, if you have diabetic person who has progressive loss of kidney function with reducing GFR, then the blood pressure control becomes a little bit more difficult. But we're talking about persons who have sudden onset or they have refractory hypertension. First, you have to think about secondary hypertension, secondary causes of hypertension, or you may want to think about resistant hypertension. But it also says that we need to be careful of labeling this person as having diabetic kidney disease. Now, suppose they have signs and symptoms of other systemic disease. Suppose they have signs and symptoms of thyroid disease, of hypothyroidism, then that cannot be attributed to diabetes. We also say if you have diabetes and is relatively being sort of maintained, you've remained in the microalbuminuria, your urine albumin creatinine ratio is around in the 30s, and all of a sudden the person presents with massive proteinuria or nephrotic range proteinuria, that should not be ascribed to diabetic kidney disease. And that is somebody you probably might want to consider referring. So how do we now monitor these persons? Monitoring obviously would depend on the recognition of the different complications that comes with diabetic kidney disease. This hasn't changed. We know that diabetes comes with the microvascular complication and it comes with macrovascular complication. Most persons are familiar with microvascular complications. We look for symptoms that may suggest TIA or stroke. We look for symptoms that may suggest angina, whether stable or unstable. We will do ECGs on this patient. We do echocardiograms. We had just had a lovely lecture on ulcers, but I'm sure most persons, even if you don't see any ulcer, you look for that symptoms of diabetic peripheral neuropathy. You might even want to palpate to feel for the pulses in terms of diagnosis of peripheral vascular disease. Now, on the microvascular side of things, it might be a little bit of a challenge to look for retinopathy, but you could ask them about any visual disturbances from the kidneys. We're going to be screening them, and then we have the neuropathy. And do not forget autonomic dysfunction, which could manifest itself as probably just person having diarrhea alternating with normal bowel movement, or in a diabetic that is not on a beta blocker, you might find that they have a resting tachycardia. So this is the spectrum of what you need to do to monitor from prevention of diabetes. So which means the best treatment for diabetic kidney disease is to look for those persons who are at risk and prevent them from developing diabetes in the first place. So things become important. So those persons who may have impaired fasting glucose, or those who may have impaired postprandial glucose, or those persons who may have family history of diabetes, whether type 1 or type 2, and those who have increased BMI or increased risk for cardiovascular disease. Then when they develop proteinuria, how do we slow the progression to eventually leading to proteinuric state? Endothelial dysfunction is a common pathway for not just diabetes, but for other cardiovascular disease. So look for microvascular and macrovascular event. Endothelial dysfunction in the heart remodeling leads to hypertrophy. And hypertrophy, if it's not abated, can lead to myocardial infarction and heart failure. In the vessels, it leads to plaque, and then plaques can rupture and give you TIA, stroke, dissections. In the kidney, we have microalbuminuria, mild insufficiency that can lead to overt proteinuria and end-stage renal disease. But also what we need to do is to advise the patient and ask about erectile dysfunction. Penile insufficiency could be just another marker of cardiovascular disease to come in this patient. So this slide is just a continuum of disease relationship based on GFR of any persons or any person with kidney disease. At the initial stage of stage 1, stage 2, stage 3, stage 4, hyperfiltration or preserved GFR is what you're going to see. And in that case, those persons may have microalbuminuria. So not just your diabetic patient. So you might have a patient with lupus. Then you're going to see those early stages of microalbuminuria. And as time progresses, when they start to get to stage 3, then you might start to see macroalbuminuria. Now, I want you to pay attention to this. If you're using serum creatinine as a marker, you will have had to wait until the person has reached stage 3, or they will have lost 50 to 60% of their renal function before you can make a diagnosis of renal disease. So therefore, it is imperative that we use estimated GFR to look at this person based on the calculation. And I think the CKD EPI formula is what is advised. But we have to be careful when you start to get to stage 4 and stage 5 in terms of the relationship. Now, if you look at the top of the chart or the graph, you look at hypertension. As you progress to stage 1 to stage 5, you're going to see development of hypertension, and your cardiovascular risk function, and your cardiovascular risk also increases. Now, in order to try to save anything, you have to do your prevention in the early stages, because once it has been established, the only thing you can do is slow progression of the disease. So, burden. Let's look at the CKD related complications. So, although most of these related complications can be treated by the nephrologist, but majority of them can be treated by the primary care physicians or sometimes by the internists. What are we talking about with this complication? Like obesity, right? Every diabetic who's obese or not obese, we need to have a prescribed level of physical activity in whichever combination. I tell my patient, as long as you add up to 150 minutes per week. And also, suppose you have those persons who may have some kind of physical or cardiovascular challenge, then you need to do it in gradation. You gradate slowly. In terms of protein intake for the diabetic, try and keep your protein intake to 0.8 grams per kilogram per day. Now, most important in terms of calorie is my explanation to most patients with diabetes and diabetic kidney disease is think about this as expenditure, energy gain and energy loss. So regardless of what you do, what level of physical activity you think you're doing, if you're not in an energy deficit, you will not be able to attain your goal. So a good way is if you can lose up to 700 kilocalories per day, then you could probably be on your way to weight management. Now, what about diabetes itself? What is the target HbA1c? So we have different guidelines. ADA says, less than 7, less than 6.5, but we need to consider the person's risk for hypoglycemia, their cardiovascular status, and also the duration that they've had diabetes and if they've had suffered from complications of diabetes. Now, we also need to consider the drugs that are available for patients with advanced CKD. So there's some drugs that we can use in most diabetic patients, but as they have advanced kidney disease, then you might have to alter these drugs, and that also includes metformin. And then we speak of therapeutic lifestyle change or total lifestyle changes, we need to advise them on exercise, smoking, and the need for medication adherence. Now, just a note on using HbA1c. It's not problematic right across the board, but it can be problematic when you start to get to advanced stage CKD, and certainly for those persons who are on dialysis because of mechanical destruction, and you might give you a falsely low HbA1c, giving the impression that the patient is controlled. So therefore, we need to try and rely on other things like the random blood glucose in the office reading. I do ask them every time I see a random blood glucose, I try to put a relation to when they last had their meal. But importantly is if they can do home glucose monitoring. Now, early intervention with the drugs. So 2020 guideline on hypertension management is sort of moving away from using monotherapy to dual therapy. And I believe that's where we're going to go with management of type 2 diabetes, because there are several drugs that can be used. So you can use a low dose of different drugs in combination to attain, the benefit, and at the same time reducing the side effect. And this study is basically looking at those persons with type 2 diabetes and looking at HbA1c. So you're treating persons with the conventional stepwise approach where you use one drug. When you don't get the target, use another drug, and you titrate upwards, as opposed to giving them an earlier and more aggressive intervention. What you find is that the patient is more compliant and you get a better result and a faster time to reduction in HbA1c. What about hypertension? So with a diabetic person, even with normal blood pressure, if they have proteinuria, you need to consider use of RAS blockade, renin-angiotensin-aldosterone system blockade. Now, if they do have hypertension, then you need to treat them to target, and you have different guidelines and what target blood pressure it should be. Cardiovascular disease, there is a linear relationship between albuminuria and cardiovascular risk. So we need to consider that. So the patient moving from low, what we call micro to macro to overt albuminuria, then we have increase in cardiovascular risk. So the use of ACE-ARB or sometimes calcium channel blocker to reduce proteinuria becomes important. Also, when you look at the GFR also, as your GFR falls, then there's an increase in cardiovascular risk. And the use of drugs that can lower lipids, that is also something that needs to be considered. And all the guidelines recommend the use of statin in a diabetic person, whether they have high blood pressure or not. And the target should be less than 1.8. Now, what about the CKD specific complications now? Now, these are the ones that will occur later in the course of the disease. Typically, when they get to stage 3, probably stage 3B, then you start to see this. And these are best managed by the nephrologist. And emphasis, though, should be that even for the persons who are non-nephrologists to be able to identify these things and also monitor along with the nephrologist so that you can abate the complication before they arise or just once they've occurred. So what about anemia? We should all expect a normochromic normocytic anemia if it is due to CKD. And it also depends on CKD stage. So I wouldn't expect somebody with CKD stage 1 or 2 to have anemia. Now, we need to also ask screening questions that are gender and age specific that can also cause normochromic normocytic anemia, because some malignancies or some other chronic diseases can also give you normochromic normocytic anemia. Now, we need to consider the use of erythropoietin and the dosing once it is appropriate, and supplemental iron. Now, there is the use of not just iron alone to give us folic acid supplementation or vitamin B12 supplementation. So if you can find a drug that has everything in one, that is usually my recommendation to to allow for compliance. Plus your diabetic patient on average is already taking 6 or 7 drugs already. What about mineral bone disease, CKD, MBD? So there's an increased risk of cardiovascular events. So we need to look at the calcium, the phosphate, the uric acid. These are all the things that will contribute to advancing or progressive of the disease process, but also it will contribute to cardiovascular event. We need to consider dietary and use of phosphate binders. Dietary important, so the patient can be aware, not just for mineral bone disease, but also in terms of hyperkalemia, food that are high in potassium. So they need a referral to see the dietitian. So in conclusion, the role of the primary care physician in the management of patients with type 2 diabetes, I think the first is in the general population. There's a commitment in the general population to try as much as possible to reduce the impact of development of diabetes. And if you can reduce that prevalence, then the number of persons who have diabetes and diabetic complications will also significantly reduce. We need to understand the risk factors for diabetic kidney disease, those persons who are going to develop it, so we can identify them early and then we can institute appropriate intervention. And effectively, we need to use screening methods and treatment strategies and refer early when you're in doubt so that we can have a better outcome. Thank you very much for your participation, and I do welcome any questions at this point.
Thank you very much, Dr. Suivo, for that another excellent presentation. We are running a little against time, but we will ask those of you who have questions for Dr. Suivo to type them in to the question and answer section. And we are now going to try and go through some of the questions. We have approximately 10 minutes, so 5 minutes for each presenter. And I am going to pose to them some of the questions that were asked by participants. So starting with some questions for Dr. East. Dr. East, first question, since iodine and gauze are for the sloughing, what then should be used to clean and dress wounds in the public health centers? Dr. East, are you with us?
Yes, I'm here.
Okay. The question is, what should be used to clean and dress wounds in the public health centers?
Not one of the caustic solutions. Savlon is a good cleaning agent. It's certainly not as caustic as povidone iodine. And we really don't have an option in the public health sector, an option apart from gauze. You just have to be gentle in your cleansing. You can also use irrigation to help remove some of the slough and the debris. But we don't have many options beyond gauze. Just avoid those irritating solutions once the wound is clean. During the slough phase, the inflammatory phase, feel free to use them. But once that has settled down, use normal saline or Savlon for cleaning.
Thanks for that. Dr. William Brown is asking, could a combination of Trental and Daflon be used in a suspected arterial venous leg ulcer?
Arterial venous?
Yes, he's saying if there's a combination venous, could you use a combination of Trental and
The evidence for Trental is not impressive, and I've used it in many years.
Okay.
I think it's not impressive. It's not impressive. None of the pharmacological agents are very impressive once you develop critical limb ischemia.
What about the use of Neurontin in a neuropathic ulcer?
I must admit I don't remember what Neurontin is. Just remind me. Mr. Brown?
It's along the lines of things like gabapentin.
Yeah, correct.
Oh, that's not for ulcer treatment. That's for neuropathic pain.
Okay. Brittany Clacken is asking, can you elaborate on the use of antibacterial ointments in wound care?
Yes, I I did mention that they really have no role to play. There's no evidence that they make any difference to wound healing, and in fact, they may encourage resistance, emergence of resistant organisms. And the reason for that is that there's a biofilm that antibiotic creams and ointments are not able to penetrate.
Okay, thanks. And Professor Morrison is asking, in the management of diabetic ulcers, have you any experience with, or would you comment on the use of topical insulin application?
No.
You don't have any, you've never been exposed to that?
No experience and no knowledge of that.
All right. I know that on one of your slides, there was a mention of it, but Dr. Dinga is asking, is there any benefit of hyperbaric oxygen therapy chambers in wound care? I know it was on your slide. You want to expound on that?
Yes, the research hasn't been convincing. Researchers have also used ozone, but not convincing.
Okay. I see a number of other questions. I don't know. Let me see if there are any other. Someone was commenting that there are certain orthotic and diabetic footwear available in the private sector. Dr. Howell Taylor wanted to know, for an obese patient with peripheral venous insufficiency and on lifetime warfarin, but without ulceration, are there any benefits or risk for ablation of varicosities?
I would be inclined to use non-operative, non-interventional therapy like support stockings in that patient.
Thank you. And let me see if I see one. I think you had already spoken on your views about microdosing for venous ulcers.
Yes, I only have anecdotal experience.
Anecdotal experience.
As I said, there's a paucity of solid research evidence, but I do have favorable personal experience with its use.
All right, thank you very much. Let me see if there are any questions for Dr. Suibo. I am not currently seeing any. I don't know if let me go back to the the open questions. Professor Reed, I don't know if you are seeing any questions for Dr. Suibo.
Nope, no questions for Dr. Suibo. I think his presentation was that spot on. Everyone got it and it was very clear.
Okay.
I may say the only question that Dr. posted here is the use of fructosamide, fructosamine in monitoring diabetes. So we spoke about HbA1c, which is sort of, it gives you a 3-month snapshot of what's been happening with diabetes control. Fructosamine gives you like a month to see what's happening. So it's something that you can consider using, but I don't think it's available clinically as yet. And those are things that are being used for research.
Okay, thank you very much for that. I think that at this point, we can conclude this session, not to preempt the vote of thanks, but just to say our personal thanks to both Dr. East and Dr. Suibo for very clear, pointed presentations, which are of use to us as family physicians. We thank you both for taking the time out on a Sunday morning into the afternoon to share with us. Thank you very much. And I will now hand over through Professor Reed to Dr. Williams-Green to take us into the third section. I know there should have been a break, but I think we are all in this virtual space able to take breaks of our own. So Dr. Williams-Green or Professor Reed, I would hand
So
over.
while Dr. Williams Green gets ready, we're going to hand over to Paul Russell from Abbott to do a quick 5-minute presentation from Abbott, our sponsors, followed by Amo Rickman at H2K. After that, Dr. Williams Green will do her introduction of session 3, which starts with a presentation from Indus Life Sciences. Thank you so much to the presenters, and thank you so much, Dr. Standard Goldson.
My pleasure.
All right. Sir
Hearing me?
Russell, up to you. Yeah, I'm hearing you clearly.
Okay. All right. Good afternoon, CCFP. Thanks again for the opportunity to address your membership. My name is Paul Russell, and today I'm going to be reminding on some of Abbott's products present in the Jamaican marketplace. For the hospital setting, we see our tube feeding presentations, Glucerna. We have Glucerna 1.2 cal, and we also have Glucerna 1.5 cal, which is for your type 1 and type 2 diabetes or abnormal glucose response for hypoglycemia resulting from metabolic stress, illness, trauma, or infection. They're calorically dense formulas that have low glycemic carbohydrates, clinically shown to help minimize blood glucose response compared to standard formulas. They come as vanilla flavored, they're kosher and halal prepared, they're gluten-free and suitable for lactose intolerance. Now, for commercial use, available in our supermarkets and pharmacies, we have Glucerna Hunger Smart, Glucerna Shake, and Glucerna Snack Shake. For Glucerna Hunger Smart, this presentation has 15 grams of protein, 180 calories in 10 fluid ounces.
Mortality globally, self-management and prevention, primary
fiber, 6 grams of fiber, and comes in assorted flavors. And it also has essential vitamins and minerals. For Glucerna Shake, it has 10 grams of protein, also 180 calories, a fiber content of 4 grams, comes in an 8 fluid ounce container, and it has your essential vitamins and minerals, and it has assorted flavors. Available in the Jamaican market is vanilla, chocolate, strawberry, and butter pecan. And for your Glucerna Snack Shake, we have 140 calories in 8 fluid ounces. It has 7 grams of protein, 3 grams of fiber, has your vitamins and minerals, and it comes in vanilla and chocolate. Now, all our Glucerna preparations are kosher and halal prepared. They're gluten-free and they're suitable for lactose intolerance. And coming soon to the market is going to be a Glucerna Hunger Smart powder. It comes in a 22 ounce tub, and each 8 fluid ounce serving gives 130 calories and 22 grams of protein. Now it will be coming in vanilla and chocolate flavors, and it should be available to the market in the next 2 to 3 months. So you can look out for that. It's going to be available through CARMED and will be in most every supermarket. This also is a kosher and halal prepared presentation, gluten-free and suitable for lactose intolerance. And just a reminder for wound healing, we have Juven, which has a unique blend of key ingredients to support the wound healing process. Contains arginine, glutamine, HMB, hydrolyzed collagen protein, and micronutrients. And this combination supports wound healing in just 2 weeks. And it's recommended 2 servings per day. Comes in fruit punch and orange flavored sachets to be mixed in juice or 8 fluid ounces of water. As I mentioned before, my name is Paul Russell. I've left my cell numbers there, 489-6093. I can be contacted through Carimed at Lady Musgrave Road. My email address, which is not here right now, it's paul.russell, but this Russell is spelled with one L, as we have two Paul Russells in Abbott, one in the United States. So it's paul.russell@abbott.com. You can just shoot me an email and I'll respond to you as quickly as possible. Thank you again for the time.
Thanks so much for your presentation, Paul. So we're going to go right now into the H2K presentation.
This is Health 2000 Canada, otherwise known as H2K, represented by Amoy Rickman. We are a generic pharmaceutical company proudly serving you since 1999. We are a brand you can totally trust. I will be talking about some of our ethicals and over-the-counter products, just a few today. H2K Metformin 500 mg tablets and H2K Metformin XR 500 mg tablets. Metformin is still the gold standard in the treatment of type 2 diabetes and is the rational choice due to its beneficial effect on weight, lack of hypoglycemic effects, and positive effects on lipid profiles. So we can say that metformin protects the obese diabetic. H2K Metformin XR is an extended release formulation of metformin which offers additional benefits of 24-hour control with once daily dosing with evening meals, providing uniform release, stable and sustained blood levels, as well as decreased gastrointestinal side effects, enhancing patient compliance. H2K Metformin XR is still safe and effective for use, approved by the Ministry of Health. H2K pentoxifillin extended release 400 mg tablets is a hemorrhagic agent. It works by helping blood flow more easily through narrowed arteries. H2K pentoxifillin treats problems from poor blood circulation. It reduces pain, cramping, numbness, and weakness in the arms or legs, which occur due to intermittent claudication. H2K pentoxifillin extended release 400 mg. H2K Vasogrel is clopidogrel 75 mg tablets. Clopidogrel is an antiplatelet drug used to prevent heart attack and strokes in persons with heart disease, recent stroke, or peripheral vascular disease. H2K Vasogrel keeps blood vessels open and prevent blood clots after certain procedures such as cardiac stent. H2K Vasogrel is also used with aspirin to treat new or worsening chest pain in new heart attack or unstable angina. H2K Vasogrel, clopidogrel 75 mg. H2K Meloxicam 15 mg scored tablets. Meloxicam is an NSAID with preferential selectivity for COX-2 inhibition. The anti-inflammatory, analgesic, and antipyretic effects of meloxicam are due to inhibition of prostaglandin, which are known mediators of inflammation. H2K meloxicam has proven efficacy in osteoarthritis, rheumatoid arthritis, ankylosing spondylitis, sciatica, and lumbago. H2K meloxicam has well-documented gastrointestinal tolerability. Use H2K meloxicam for rapid, prolonged pain relief. H2K loratadine oral solution 5 mg per 5 ml and H2K loratadine 10 mg tablets are long-acting antihistamine agents with once daily dosing, 24-hour control, and rapid onset of action. These are appropriate agents for the treatment of allergic rhinitis and urticaria. For seasonal allergic rhinitis, persons will get symptomatic relief within 30 minutes. H2K loratadine is also effective in the treatment of perennial rhinitis and chronic allergic disorders. Use H2K loratadine for allergy relief without sedation, also available over the counter. Borototal neem cream for wound healing and skin infections. It contains neem, aloe vera, sesame oil, asoka, licorice, and zinc. This combination makes Borototal neem cream very effective on cuts and scratches, nappy rashes, cracked nipples, insect bites, blisters and burns, dry cracked skin, minor sunburn, skin inflammation, and it is quite effective on the diabetic foot, that thin, dry, papery skin that's prone to ulcers. Keep Borototal in your cupboard, in your kitchen, in your car, and in your practice. Use Borototal neem cream. Research shows that our diets lack an appropriate amount of vitamins and minerals. Dietary supplementation provides a way to prevent deficiency. One of the most complete multivitamin and mineral syrup on the market today is in fact our Vitamax, which contains 11 of the daily essential vitamins and minerals needed. Vitamax is beneficial during pregnancy and lactation, excellent for children as young as 1 year to adulthood, is sugar-free, enhances your appetite and boosts your immune system. Make Vitamax a part of your daily immune boosting regime. Vitamax has a unique, tasty pineapple flavor. Try H2K Vitamax, available OTC. H2K Go Gel provides quick relief for muscle, joint, and back pain. H2K Go Gel contains diclofenac, linseed oil, menthol, methyl salicylate, and capsaicin. H2K Go Gel delivers medication right to the site of your pain to keep you moving and gets you going beyond your limits. H2K Go Gel. Please follow H2K on Facebook and Instagram. Please support us by writing H2K before the drug name on your prescription. On behalf of my colleagues, Chris, Almaz, Mardell, I thank you. Stay safe.
Thanks so much, Amoy. Thanks so much, Paul. And so based on the agenda that I have here, Paul and Amo are both available to take your questions. If you ask them in the Q&A, they can reply. We just want to try and catch up on time instead of doing it live. But thank you guys so much for being sponsors of the event. And I know it's been a wonderful morning and afternoon so far. So I hand over now to Dr. Pauline Williams-Green. Dr. Green, you there?
I'm hoping I'm here. Can you
I'm
hear
hearing
me?
you 100%, hearing you very
All
clearly.
right. So we've had a fabulous morning, and the speakers have been excellent to the point. And at some point, I would like the sponsors to tell us how we can get these presentations to listen to again, because they have been fabulous, very enlightening, very encouraging as well for general practitioners' role. So we're going to go on to our sponsors presentation, Indus Life Sciences. Could you go ahead, please?
Aminopep4 in geriatrics. Aging is associated with a progressive loss of muscle mass, which increases the risks of injury and disability. A 2018 Journal of Nutrients highlights that inadequate intake of dietary protein has been linked with poor muscle function and physical decline in older people. Essential amino acids, which cannot be synthesized by the body, have primary role in the regulation of muscle protein synthesis, can potentially mitigate the loss of muscle protein during aging process. To meet the increased demand and to promote nutritional status, Indus Life Sciences brings Aminopep4. Aminopep4 contains all 10 essential amino acids enriched with multivitamin and zinc. During aging, supplementation with essential amino acids stimulates muscle protein synthesis in the elderly, increases lean body mass, improves the ability of walking, provides immunity against recurrent infections, and builds up energy and vitality. All essential amino acids in AminoPep Forte are in free form, which does not need further digestion and hence can be directly absorbed. AminoPep Forte is also suitable in compromised digestive capacity. AminoPep Forte offers adequate nutrition through essential amino acids and is an essential part of healthy geriatric face. AminoPep in convalescence. Following illness, body proteins like enzymes and hormones are rapidly broken down and are insufficiently resynthesized due to lack of essential amino acids. During convalescence, there is rapid weight loss due to loss of body fat and skeletal muscle mass. This is frequently accompanied by short-term self-limiting disease process like injury, surgery, and infection. Hence, supplementation with essential amino acids promotes tissue regeneration and healing, shortens convalescence, strengthens immunity, and provides sense of well-being. AminoPep Forte supplementation strengthens body resistance and improves immunity. AminoPep Forte shortens recovery phase and hence back to work faster. In old age and convalescence, AminoPep Forte acts as an ideal nutritional supplement.
All right, and the representative for Indus Life Sciences on the call is Miss Ashley Baldwin. She's also here to take your questions in the Q&A. Back to you, Doc.
Thank you so much. And I have been told by the organizers that this entire webinar will be available by YouTube. And I imagine when you pay the money, the $1,500, you'll be able to get your CMEs as well. That's what we've been told. So we go into, we're going to end with a crescendo. And I take the baton from Dr. Sandra Golson, thank you. And I'm going to use it as a conductor's stick that they are, conducting the orchestra, because we now have two wonderful presenters, each of them presenting for 7 minutes. And we start right away. I plan to introduce them individually. So
Hi, Dr. Green, apologies to interrupt. I believe there was another element of the presentation from Indus. My apologies. Ashley, could you go ahead and present, please?
Oh.
Let me just get that out of the way. My apologies. I made a mistake. Floor is over to you, Ashley.
Thank you and good morning. Samuel, could you kindly show the slide that I sent to you, please? Or allow me to share my screen, please?
So you can share your screen. You should see the button there, option to do it.
Thank you.
Perfect. Perfect.
Good morning, CCFP. Can you hear me clearly?
Wonderful.
Great. Good morning to you. I'm Ashley Baldwin from Indus Life Sciences, and I'll be going through briefly with you 3 products. One, which is covering nerve pain, neuropathic pain management. And as we know, one of our products, Neurobalin, helps to improve the quality of life. We have both concentrations that are available at private pharmacies. And to just brief you on the price difference in the market, not bashing any brand on the market. However, the first brand is the known brand. Second is the generic. And our Neurobalin, for a pack of 30 capsules, is for $2,850 to patient. Also, 75 milligrams is covered as well as on NHF card, and it's for $3,250 to patient via your private pharmacies. We see here that Neurobalin is as efficient as the brand, as well as we have a coupon for patients who use such brand. So it says here on the coupon for both brands of Telmifast, Telmisartan, and Neurobalin or Pregabalin, you can state the patient's name, date, and if they buy 3 packs, which says 3 strips, they get 10 pills free of cost extra on their prescription. And if they buy 6 strips, which means 2 packs, they get two strips, which means 20 pills extra on their prescription. Doctor's name and signature, and your medical rep can give you one in their territory, in your area, which will expire in next year. And to show you an example, if you can see clearly or can see a bit on the receipt on both sides, it's an example of the Neurobalin. They bought 2 packs of Neurobalin, and before such, before NHF coverage, it came to $5,980 before NHF coverage. And after coverage, it came to $748.60 after NHF coverage. And because they bought 2 packs, they got 20 pills free of cost on their prescription. And moving on, we have to cover or to be prescribed alongside the Neurobalin is our Capsitop, which consists of capsaicin, diclofenac, levomenthol, methotrexate, and it's a gel-based formulation. Capsaicin inhibits substance P, which is a major pain precursor in nervous pain. Diclofenac inhibits prostaglandins. Menthol, of course, helps to soothe the muscular membrane and help with the absorption of the gel. And of course, salicylate inhibits interleukins 1 and 6. So it covers both shoulder, knee, wrist, back, and neck pain. So all your muscular, joint, and muscular pain. Coming on next is our AminoPep. It helps overall well-being of ages 18 months and upwards can take it. It consists of vitamin D3, vitamin C, zinc, arginine, amino acids, the B complex, niacinamide, folic acid, calcium, and so forth. It is known that vitamin C helps to absorb iron, also helps with immunity, as well as helps with cartilage and bone strength and health. Valine, an amino acid, helps with muscular or muscle coordination. Isoleucine helps with wound healing and immunity, as well as arginine. Lysine helps to play a vital role in building muscle, aiding recovery from injury or surgery. Histidine facilitates growth and creation of blood cells, and a deficiency in histidine can lead to anemia. Other one we have there is called tryptophan, an example of one of the amino acids we have. It's a precursor of serotonin and melatonin. And as we know, serotonin regulates appetite, sleep, mood, and pain. And melatonin helps to regulate sleep. Just to show you what the content of AminoPep is, not bashing other brands, not bashing them. However, we can see that you can have, there's a lot of ingredients in our product AminoPep. And for the price, per bottle is a 200 mils. It's in the bottle for a price of 1,500 average price at the pharmacy over the counter. Other brands on the market, you can see there where they have the content and their pricing. However, we can say that we are standing tall in regards to the content and the price point of our supplement. It contains sorbitol, so it won't affect any person who is diabetic. And because it contains a B12, it can aid in persons who are prescribed metformin, because metformin is known to reduce the B12 vitamins in type 2 diabetes. So it can be paired alongside persons who are on metformin. AminoPep Forte is for persons 18 years and onwards, available over the counter, and it's for all age groups. Thank you very much.
Thank you so much. And at this point, we may proceed, I believe. So I have received the baton from our previous moderator, and I'm now going to use it like a conductor's baton, because we have before us 4 excellent presentations, I am sure. Just letting you know that we have moved into the final third and final session, and that the topic is this time diabetes and COVID-19. I know some of us may be tired of COVID, but it's not going away. So we need to understand it in the context of, in this case, we're having a panel discussion and we're linking diabetes and COVID-19. Our first panelist is Dr. Patrice Francis Emmanuel, and she is an internist and endocrinologist at the University Hospital of the West Indies. I let you know, though, she is also a researcher, having completed her undergraduate and postgraduate training here at the University of the West Indies. Her interest in research led her to the Tropical Medicine Research Institute and later the UWI Solutions for Developing Countries. Finally, she went on to do her endocrinology and diabetes fellowship training at the West Suffolk Hospital in the United Kingdom. So we are very happy to welcome Dr. Patrice Francis Emmanuel. Each speaker has 7 minutes. So when you hear my bell ringing, you know it's time to wind up. Thank you. Let's hand over to Dr. Patrice Francis Emmanuel.
Thank you very much, Dr. Williams-Green, for that introduction. I hope everybody's hearing me.
Yes, hearing you very clearly.
So thanks to the organizers of the CCFP for having invited me to be a part of this list of panelists to sit amongst my esteemed colleagues. And over the next 7 minutes, I will just briefly be touching on a few points which have to do with diabetes and COVID-19 co-management. And I start off this little talk with a table I took from a publication by my esteemed colleague, Professor Michael Boyne, who in 2008 highlighted the enormity of the type 2 diabetes issue in the Caribbean. And if you notice, there are quite a number of our Caribbean neighbors that are listed in this table. And the crude prevalence and adjusted prevalence rates are in double digits for the most part. More local in the Jamaica Health and Lifestyle surveys between 2008 and 2018, the second and the third iteration published by Professor Rainford Wilkes et al., we see where our prevalence in Jamaica has risen from about 8% to about 10%, with about 12% of our population over 15, between 15 and 74 years old, being pre-diabetic. And of even more significance is a projection that between 2000 and 2030, we expect a rise of about 150% in prevalence of type 2 diabetes in our Caribbean population. So as the focus of our panel discussion is COVID-19 and diabetes, I will take the opportunity in the next 5 or so minutes just to touch on a few points as it has to do with management. We all know that a diagnosis of diabetes portends a high atherosclerotic cardiovascular risk. And so management of persons who have diabetes and who are infected with COVID-19 has to be quite well tailored to ensure the best outcomes. And this is not a slide that is unfamiliar to any of us here. We know that diabetes portends a high cardiovascular risk. The risk of coronary heart disease, heart failure, peripheral arterial disease, and stroke are indeed quite high and increase mortality and morbidity in this population. We have come to recognize the complex bidirectional relationship between diabetes and COVID-19 infection. On the one hand, individuals who are already known to have established diabetes, especially in the face of poor metabolic control, have been found to do quite unwell in terms of their outcome. They tend to get more serious disease.
tend to be escalated to the intensive care unit more often, and they also have higher mortality. On the flip side, infection with COVID-19 has been found to be associated with worsened diabetes control. And in fact, the question is whether COVID-19 infection itself may lend itself to the development of new onset diabetes by a number of mechanisms. So one of the first questions I'd like to pose, and a question that I think a lot of us have been engaged in and have read about, is whether diabetes itself increases the risk of infection. And we do know that a diagnosis of diabetes results in poor immune function. The risk of serious infections is increased. However, to date, there's no conclusive evidence that suggests a diagnosis of diabetes itself results in an increased likelihood of infection with COVID-19. However, the risk of poor outcomes is significantly increased. And I took this Kaplan-Meier curve from a publication in the Diabetes Care a few months ago, which shows a clear difference in survival rates in persons who have diabetes, who are infected with COVID-19 during the first 30 days of admission, compared to those individuals who did not start off with a diagnosis of diabetes. And you can see clear separation of the curves from as early as about 5 days into admission. Very often in type 2 diabetes, we are also faced with the issue of obesity. And this meta-analysis, which evaluated 12 studies, which looked at essentially a dose response, separating patients into those with a body mass index of more than 30 kilograms per meter squared compared with those who had a BMI of less. And as you can see, the odds ratio of poor outcomes, meaning severe respiratory illness, ICU admissions, and mortality, was 2.35 when compared to those who had the lower body mass index profile. So while obesity and many of the other risk factors associated with type 2 diabetes might not be immediately modifiable in the acute COVID-19 infection phase, there are certain things which are potentially modifiable and which may result in improvement in outcomes. So we know diabetes is the second most prevalent non-communicable disease in patients with COVID-19 after cardiovascular disease. It increases the risk of medical interventions, as mentioned, the risk of severity and mortality. But we do know that in individuals who have diabetes who are well controlled, the risk of poor outcomes is much less. On the flip side, in individuals who have persistently elevated glucose levels of over 10 millimoles per liter, there are the associated poor prognostic markers, which we have heard about quite often, which are associated with worsened disease severity and increased mortality. So the bottom line is that in managing these patients who are known to have diabetes, who now become infected with COVID, management needs to be individualized with specific targets set. Medication regimes need to be reviewed to ensure that patients are properly optimized, and that in the face of severe illness in patients, especially if they require admission to hospital, if they're escalated to ICU, then strict control of glycemic status needs to be implemented, avoiding glucose variability, avoiding hypoglycemia, but ensuring that glucose targets are within the recommended levels to ensure the best outcomes for our patients. Thank you very much.
Excellent. Thank you so much, Dr. Patrice. And I'm going to say that you represented the string section of our orchestra. So we look forward to hearing from you in a question and answer. All right. So now we're going to go to the horn section, all the horns, right? And the flutes, etc. We're going to have Professor Brendan Bain, and he is an honorary consultant in the Department of Medicine at the University Hospital of the West Indies, and an advisor to the COVID-19 team at the hospital. His private practice is at the Mona Institute of Medical Sciences Clinic. Well, he's an honors graduate and he's also a DM graduate. After the DM, he received a Wellcome Trust Research Fellowship in Infectious Diseases, and this was in London. He has pioneered the training and clinical care of persons living with the acquired immunodeficiency syndrome in Jamaica, and led the Caribbean HIV/AIDS Regional Training Network, known as CHART, from 2003 to 2014. In 1996, he became head of the Department of Community Health and Psychiatry. Sorry, he went to the department and was appointed to the departmental chair in community health in 1999 when he was my boss. And therefore, he's been at the university since then. We now welcome Professor Brendan Bain to again address the topic COVID-19 and diabetes. Thank you.
Thank you, Dr. Williams-Green. I'm looking for my slides. Let me see. Okay. All right, are you seeing my screen?
Yes, sir.
Okay, so let me. All right. So thank you to the organizers of CCFP of this day for inviting me to the panel. And I just want to start by acknowledging a colleague because although I thought it, she said it, and that's Dr. Tamara Thompson, who is the head of the infectious diseases team at the University Hospital. Tamara said, we have to approach COVID with a dose of humility because we are all on a learning curve. And I believe that this can be echoed by just about everybody in today's meeting. I thought I would just reinforce some of the abbreviations. Goes without saying, but SARS stands for the Severe Acute Respiratory Syndrome, and SARS-CoV-2 is the name of the virus that causes the coronavirus disease 2019. And sometimes we mix up the virus with the disease. The natural history of COVID-19 is shown on this slide. And I want you to pay attention to the unfolding over time and the days that can pass after exposure. The average time before symptoms develop is 5 days. And then by 12 days, if a person is going to get very ill, that begins to happen. The best estimates of severity with no intervention are as follows. 40% of persons have no symptoms at all. 50% have mild symptoms, and 10% go on to the severe manifestations of the disease, with that 10% really needing hospitalization, but only 3% being so severe that they need intensive care management. Late presentation can change the 10% and 3% figures. And that's something that really bothers us in Jamaica. And I don't know if the men are taking longer to get to hospital than the women. I don't have those data. But the average time to show symptoms, as was mentioned, is day 5 after exposure to an infected contact. And there's wide variation in when patients come to hospital. And late presentation, just to repeat the point, can adversely influence outcome. I bring this slide back for reinforcement. Now, Dr. Francis Emmanuel has already made a couple of these points, but again, repetition is good for reinforcement. But the American Diabetes Association in their March 12th release was careful to say this information is based on current knowledge of COVID-19 and will be updated as additional scientific evidence is released. Reference to the learning curve. So, are people with diabetes more likely to get COVID-19? This is the risk of contracting the infection. So far, we cannot say that for sure. There's not enough data to show whether people with diabetes are more likely to get COVID-19 than others. However, as has already been said, they're more likely to have worse complications if they get it. Okay. And it was hinted at in Dr. Francis Emmanuel's presentation, the more health conditions someone has, the greater their risk of getting serious complications from COVID-19. And as we get older, older people also have a higher hit list, higher risk of complications if they get the virus, because complications multiply as we get older. Now, I got a very interesting and important list from the CDC, published in November of last year, categorizing people according to the underlying problems that they have, those with the strongest and most consistent evidence of impact. And these lists by CDC are set up alphabetically, but I put in bold the ones that are most relevant to us here in Jamaica. Maybe we should have put cancer in bold, and the list goes down the left and then comes back on the right. So you see chronic kidney disease, type 2 diabetes, obesity, especially severe obesity, pregnancy, sickle cell disease, and smoking relevant to Jamaica. For conditions with lower evidence of impact, CDC calls this mixed evidence: asthma, chronic kidney disease, cerebrovascular disease, hypertension, and use of corticosteroids or other immunosuppressive medications. All of these are relevant to Jamaica. Limited evidence of impact so far as we know, based on the American data. And the ones that are placed in bold are diabetes type 1. Notice that there's limited evidence from research compared with type 2, and HIV, limited evidence of impact on the severity of COVID-19 once a person is exposed. So that's my slide set. And what I would say in summary is that it does not seem that any of these conditions increases the risk of contracting COVID-19, but how a person battles with COVID-19 does depend on what the person's comorbidities are. So I'm going to hand back to our moderator, Dr. Williams-Green. Thank you.
Thank you so much, Professor Bade, and for sticking to time. And now we go on to the, we did the string and the horn, so we're at the keyboard. So we're going to go to the keyboard section, which is Professor Michael Boyne. All right, he's also professor of endocrinology and metabolism, and also the head of the Department of Medicine. The University of the West Indies at the University of West Indies. He's also honorary consultant at the University Hospital of the West Indies. He has authored, just like everybody else, numerous papers, but his research interests include the roles of factors in the early life. He's a member of several associations, and he is the immediate past president of the Association of Consultant Physicians of Jamaica. So let's hear from the keyboard section, Professor Michael Boyne. Thank you.
Pauline, too kind. But thank you everybody for the invitation. I hope you can see my slides, and I, like others, may give a little bit of repetition, but I think I'll build on a couple of areas in the short time period. So I just also wanted to say that COVID is associated with a lot of authorities trying to not just but there are many cardiac complications, and I'm sure our renal and colleagues will also make mention of that. But of course, the endocrine system is not immune. So there have been reports of developing new onset diabetes, ketoacidosis, and even new onset type 1 diabetes. And some of you may have even seen this report. And as Patrice mentioned, that there's a bidirectional relationship with COVID and diabetes. So persons with diabetes tend to get more severe COVID disease, and COVID disease may incite new onset diabetes. And matter of fact, there's a worldwide registry now trying to figure out how often this occurs. Now, this is not unique. There are many times when persons have an acute illness, especially an inflammatory illness like COVID, which precipitates inflammatory disease like type 2 diabetes, even 1 diabetes. So more data is still being collected, and you may be seeing some of that in your practice. But as was said before, if you're diabetic, are you more likely to get COVID? And as Professor Bain mentioned, it's the evidence for that is weak. But we are probably well agreed that the outcomes are much worse. And the outcomes in this bidirectional relationship are worse, as is seen here, that when an individual has SARS-CoV, the beta cells and many of their organs also carry the ACE2 receptor. And as we know, this is the binding site for COVID, and this can allow theoretically for the worsening of resistance and decrease insulin production. As it gets worse, and as the blood glucose goes up, their outcomes get worse. My patients always ask me, am I, how much at risk am I? And this study gives us a little bit of insight that persons who have very well controlled diabetes entering, if they happen to get COVID, their risk is very similar to non-diabetic persons, maybe about 1 to 2% mortality rate. So, but if their A1C is 9% or above, their death rate tenfold increases, right? So the death rate jumps up to about 11%. So it's important for all of us to ensure that good control is being had even in these difficult times on a happen chance if the patients actually do get diabetes. And we also know that when you look at worldwide, and even here in Jamaica, many of the persons who have died from COVID are obese and also have diabetes. And cytokine storms are more common in these individuals. The challenge we face in the outpatient setting is the interruption of diabetes care because of COVID. So they get sick and they get acutely ill, and the sugar goes up and out of control, or they can't get to their usual care in terms of clinics, appointments, pharmacy, refills, etc. And all of these things, and with each cycle of a surge, helps to unfortunately worsen. So it's really part of it is the social factors that are related to COVID, interrupting diabetes care, both acutely as well as clinically, chronically. But here's some interesting data that is tantalizing. patients who are on metformin, there's some observational data to suggest that metformin may actually be prevented. So this is not metformin when they are acutely ill. In other words, if they had been on metformin before and then became acutely ill, there seems to be some protection against mortality. And this remains to be tested, but it is interesting to see this, especially because we have a lot of patients now who have been coming off metformin thinking the bad is applied to them and metformin is bad news. But this is interesting data for our patients. But I think that when we look at therapeutics, all of our patients, well controlled is the way we go. And we use a variety of medications, and they may help in various ways, in either in decreasing inflammation, like some of the agents. Some of the agents, such as pioglitazone, may even have some beneficial effects on the lung, and as well as mentioned, metformin and some perhaps tantalizing data with DPP-4 inhibitors may also have some COVID improvement. However, when persons are critically ill, the king drug is insulin, because many agents may not be so relevant during that time period. Now, for those of us who treat hospital patients, we have seen DKA emerging in these individuals. And unfortunately, DKA and COVID is a very lethal combination. As you can see here, mortality is 6-fold greater. Acute injury is 3-fold greater. They require extraordinarily higher amounts of insulin to try and normalize them. They take longer to resolve. And so one of the things also for a hospitalist patient, when that person comes in and they have DKA, you're going to have to work harder to get them under control. Now, as it relates to vaccination, you probably are getting calls like myself from patients who say, should I go and get vaccinated? And of course, the answer is yes, go and get vaccinated. But I wanted to bring this interesting concept of what is here now called as COVID age. In other words, diabetic persons, when they get COVID, their mortality is disproportionately higher as they're acting older. And what do I mean by this? So very quickly, if you are 30 years old with diabetes and you get COVID, you act as if you have COVID as a 54-year-old person. If you are 50 years old and you had diabetes and got COVID, you act as somebody who has the mortality rate of a 66-year-old person. And it starts to normalize as we get closer to the very elderly. But the point is that younger people with diabetes act as if they're elderly people who have COVID. So that is something that we have to be concerned about. And finally, this slide here, as we think about our older individuals who have diabetes and how we try to provide care for them during this time period. Sometimes during these sessions, we have to remember a few things. One is the psychological stress that they're undergoing. Please remember this, maybe to even screen for depression. Please try to give them liberal prescription refills so they don't run out. We may have to adjust into some offline ways of treating our individuals, but we need to try to keep it simple, as well as not abandoning the principles of care as we try to treat our patients during this ongoing pandemic. And with that, I thank you for your time.
Thank you so much, Professor Boyd, and we hope you'll be able to expand on those challenges for the older adults with diabetes in the question and answer, because I'm sure we'll be interested. So now I take my baton or my wand and we move on the topic of COVID-19 and diabetes. We move to the percussion section, and this is Professor Marvin Reed. He is past director of the Tropical Metabolism Research Unit at the Caribbean Institute for Health Research and associate lecturer in the Department of Community Medicine and Psychiatry, also at the University of the West Indies. Professor Reed practices as a family physician and is a member of the Family Medicine Specialty Board at the UWI. And in this capacity, he advises on postgraduate family medicine. He's also chair of the WONCA North American area, and he is a member of many other medical groups. As well as being one member of the Research Advisory Committee of CARFA. And so at this time, from the percussion, we welcome Professor Marvin Reed.
Hi, thanks, Pauline, for that. Colleagues, welcome, and thanks again for taking the Sunday to have a shirt with us. I only have 2 slides, so clearly I'll be finished long before my 7 minutes. So you will recall at the beginning of this session, we spoke about health systems and how health system can be geared or tooled, fine-tuned to interact or manage chronic diseases. I deliberately didn't go through a lot of the personal interactions, which I expected Professor Boyne and Patrice to allude to, as well as Professor Bain. And so what I will focus on is really a systematic approach and to update the audience on some of the things that we're doing as a college to assist this particular process. One of the things we recognize is that as time goes by, it's likely that COVID-19 disease itself may be moved from the realms of the purely an acute illness to that of a chronic illness with florid or varied manifestations, whether from renal, nervous system to endocrine dysfunctions. Professor Boyne alluded to some of that in his presentation. And what I want to leave with you is really the fact that irrespective of the chronic diseases, there's a generic approach that we have found that works when we're dealing with chronic diseases. And you know, Professor Musa alluded to the C's and the A's and so on. But all of that comes into or can be placed under the rubric of what we call the chronic care model, which has been advocated by the World Health Organization as a model that we should be using or thinking about as we address chronic diseases. And in that model, you have your health system and how you organize your care, you have your community resources, you have informed patients that can participate in self-management, and you have the healthcare team, which is designed to ensure that we can, and is configured to ensure that we can get the best results from our patients as a group. And so as we look through that, we now look at what the current scenarios in Jamaica. And so as Prof. Boyne alluded to, there are issues as we now speak to access of care. Where also there's issue as to relates to what are the appropriate guidelines, what chronic care guidelines are we supposed to be following as we manage these individuals? And then what specific treatment? If you recall, back in December, the Caribbean College, along with the Association of General Practitioners, partnered with the Ministry of Health to present the updated guidelines. And that is in an effort to try and ensure that as a physician group, we are cognizant of how it is that we should be managing our patients so that we could get better care. With regard to the access of care, one of the things that we have worked assiduously with the ministry is to ensure that we implement the public-private partnership to ensure that there's continuity of care of patients across both the public sector and across the private sector. And we plan to continue to work with them to ensure that this process, it continues. In May, we'll be presenting with them again further details of the screening protocol to ensure that we can identify and diagnose individuals who are coming up with these cardiometabolic diseases relatively earlier, and where possible to try and prevent them so that we don't have the full-blown burden of dealing with a chronic disease. And then the final thing that I would just wish to mention briefly is this whole aspect of treatment. Diabetes, as we know, is a very complex disease affecting all organ systems. But irrespective of how complex it is, one of the things that will always be relevant is really the role that diet will play in terms of both the pathogenesis and in terms of the treatment. So I'm not going to go into any of the fancy drugs. I'll leave that to Patrice and Mikey. What I will wish to speak to about is that as the COVID-19 emerged, we saw a flurry of things on social media about what are the things that we should be eating, what are the things that are going to kill the virus, what are the things that are going to address the diabetes or other non-communicable diseases. I want to reassure the audience that most of these data or most of these positions that have been put forward have not been tested, have not been shown to meet the normal rigors of evidence that we would like to practice on. And within that context, as far as we know, I would like to present to you the fact that our dietary-based, food-based dietary guidelines still remains the most relevant technique to manage individuals with chronic diseases. And the dietary guidelines really speaks to the fact as to how it is that we should proportion how we eat. And this is important because of the fact that with the stay-at-home orders, we'll find that the dietary patterns of most people will change. There may be an ingestion of more calories, there'll be less exercise. Both factors will contribute to worsening of your diabetes status. So as we engage with our patients, we just want to reemphasize and provide them with some guidance that they should try and eat food from all food groups, especially fruits and vegetables, and to introduce to them the so-called food-based plate, which gives them a rough idea of the proportion of things that they should consume on a daily basis. And with that, I close and hand you over back, Madam Chair.
Thank you very much, Professor Marvin Reed. And yes, I think that was a fitting end. It all boils down to what we eat. So at this time, we're going to bring all sections of the orchestra together. So we're going to have the string, the horn, the keyboard, and the percussion all together as we discuss the whole issue of COVID-19 and diabetes. And we welcome any questions in the chat. I may need some help with this, Prof. Marvin. Let me just see as I try and see the questions. But I'm going to be selfish and start with my question, which tries to bring everything together. And any member of the panel or all members can address this. How can we use the CHAs, or is there a role for the community health aides in helping us in managing the NCDs and COVID-19, but in particular diabetes and COVID-19? What are the roles? What should we be doing about our CHAs?
Well, I think I'll start here and then perhaps I'll allow some of my other panelists to comment. But where I see them is that as in Prof. Musa's example, your community health aide can provide you with some basic data as to the composition of your community that you're serving. That is, those individuals who are likely to be at risk through the administration of simple questionnaires and so on, to identify individuals who may have challenges in terms of access to care, and to also to reinforce whatever message or messages that you would like to convey as part of their management. So I think having these, what I call local or community champions, are an important tool in our armamentarium to deal with or address the chronic diseases in any community.
Thank you. Please, anyone else in the panel?
Let me just make a brief comment. It's clear that when somebody has the acute infection, that the community health aides may not have a practical role because there is the need for isolation for the sake of the patient, for the sake of the caregiver. So that's a role for the other aspects of the other elements of the healthcare team. But I think in helping people to understand real risk and to take preventive precautions is one of the important practical areas where community health aid can help. I have found that there's great difficulty in the public domain of understanding what these viruses are. The magnified views that we see on television and on flyers are not the real virus. In fact, I'm still trying to figure out how to talk about viruses to people. I mean, I've had advantages. I've worked in a virus lab before I started med school. I did research in a microbiology lab in London. I am understanding magnification, but a lot of people don't. And so there's a lot of disbelief in the community, and we need to brief our community health aides, and we need to do the necessary translation.
Thank you. Excellent point. Others?
I do also share the point of my colleague panelists. Community health aides are a very integral part of our health system. They are usually the ones in the ground in the communities. They are well aware of the specific needs of our patients in our communities. And while Professor Bain mentioned the role of the community health aides might not be as significant in persons who are actively infected, in those who are known to have chronic illnesses, assisting them in identifying specific needs, conveying information between the health system and the patients to ensure that their lifestyle interventions and other needs are met would be important to make sure they're in the best setting. So should they become infected, which we're hoping that that can be prevented, their risk of severe disease is less because there is better control, having had that baseline communication at the community level.
Thank you, Professor Boy.
I think people have spoke very eloquently, so I just agree.
Yes, somebody in the chat mentioned, I think it's Dr. Sandwin, that unfortunately CHAs are not provided with basic equipment such as a blood pressure machine and a glucometer to take with them when they go to do the visits. And this would be an issue. Somebody else is asking, with persons with underlying conditions such as diabetes and hypertension, what precautions should they take before the vaccine? Would you like to take that? Before taking the vaccine, there's a concern about taking the vaccine because they have diabetes and hypertension. Any concerns there, Professor Boyne?
Well, I get that question a lot. Yes, the concern is that, as I tell the patients, the concern is that you're very high risk for the consequences of catching COVID. And therefore, my concern is that you take the vaccine. I think most of it is just trying to handhold some of the patients that it is okay, that you can proceed, etc. Now, we do know that you may have some persons with extraordinarily rare disease conditions. They may be actively immunocompromised on, chemotherapy, etc. And some of those are slightly different, as well as the very frail patient who may not withstand acute febrile illness as a post-vaccine complication, but they have to be very, very frail. But 95% or more of our patients with diabetes, hypertension, they're not in that category. And I just encourage them to go ahead and take the vaccine.
Thank you.
I agree with Prof. Boyne. And I would just add a little piece of post-vaccination monitoring and care. And that will be for the patient's reassurance and also as we gain experience in the health system. Because as we learn, we pass on our learning to other persons.
Thank you, definitely. So we should be recording this. So are our researchers recording this? Because we recording what's happening post-vaccination.
Professor Boyne?
My understanding is yes. There is some data that is being gathered post-vaccination as part of standard pharmacovigilance sets of activities. You must recall that we're using vaccines under an emergency authorization, not because they're approved. And so as that whole system all over the world involves a higher level of pharmacovigilance, meaning monitoring of people post-exposure.
Thank you. I'm happy to hear that. Our time is up, but thank you to our excellent presentations that were well thought out and within time. And as members of the orchestra, I think you did an excellent job each. Well, you'll be more able to thank later. At this time, we're going to have a sponsor's presentation, or do we not have us? Can you let me know, Sam?
I don't believe there's any more sponsor presentations, is there? Let me double check.
All right. If there is none, it doesn't have a name, so there doesn't seem to be anybody. So we're well within time at this time. Thank you for the opportunity to moderate this wonderful session. And we're going to ask Dr. Arlene Henry Dawkins, who is a board member of CCFPJ, to give the vote of thanks. Thank you.
So Arlene, but before you give vote of thanks, just because I know we tend to go right after that, just want to encourage the nurses and doctors on this call to help the Ministry of Health in terms of their vaccine rollout. I did post in the chat earlier the link for you to sign up to do the training session, as well as to indicate what your time that you would be available to volunteer. They're hoping to start the blitz in April or as soon as the next batch comes in. So it's important for us to participate as part of our public duty, civic duty in this exercise. I'll post it in the link again before we sign off. Go ahead, Arlene.
Good afternoon, everyone. I have the great honor and pleasure this afternoon to deliver the vote of thanks as we bring today's session in the distinguished lecture series on diabetes to a close. We have had a feast of excellent practical presentations from all our speakers throughout the day. We trust that you have found it very informative, useful, and pertinent to the situations you encounter, while delivering much needed and valued care to our diabetic patients in your lives daily. First, we'd like to thank Professor Shabir Musa, our keynote speaker, for his excellent presentation on primary health care and how the system addresses health problems. We value all the points in his message, and the theme that resonates a lot with us today is with the increasing prominence of NCDs as leading causes of mortality globally, self-management and prevention are primary strategies being promoted in management of these NCDs. The 5 A's in consultation is proposed by PAHO as a universal tool for improving NCD management, and community-based interventions is also crucial. We wish to thank Dr. Maxine Cargill for the opening prayer, Professor Marvin Reed for the welcome and the introduction of our esteemed guest speaker, and Dr. Steny Onanujo for greetings from the Caribbean College of Family Physicians of Jamaica. Next, we'd like to thank the awesome presenters, Dr. Jeffrey East, Dr. Adidamola Soyibo, and our panelists, Dr. Patrice Francis Emmanuel, Professor Brendan Bain, Professor Michael Boyne, and Professor Marvin Reed. They contributed significantly to today's overall enlightenment and experience with excellent, clear, practical, relevant presentations. We thank you all for taking the time on a Sunday to share your wealth of knowledge with us. We also wish to thank the moderators, Professor Marvin Reed, he's been very busy today, Dr. Aileen Standard-Goldson, and Dr. Pauline Williams-Green for their role in keeping the discussions focused, lively, and up-tempo. We'd like to thank the sponsors of this session, without whom the events would not be possible. Health 2000 Canada, Sanfer, Indus Life Sciences, Abbott Nutritionals, and Merck. We trust that we can continue our partnership with you for future sessions. We'd like to thank our hosts, the Caribbean College of Family Physicians, Jamaica chapter, for organizing and delivering another high-quality event. We also need to recognize all the behind-the-scenes technical and administrative support personnel, Mrs. Lynn Thompson-Hyatt and Mr. Samuel Heron, for handling the registration, coordination, communication, and the technology to facilitate delivery of all that's involved in this meeting today. And of course, we need to thank all you attendees for taking time out of your busy schedules to attend and to participate. We also want to say a huge thanks on behalf of all your patients that will benefit from the lessons we have all shared and learned here today as we continue working to improve the health and of the human capital in Jamaica and the wider global community. In the event I may have omitted anyone, a general thank you to all those who we may have overlooked unintentionally. And so we bring today's session to a close. Walk good, and God bless, and be safe. Thank you.
All right. Thank you so much, Dr. Arlene Henry Dawkins, and thank you to everyone for attending the part that a lot of persons are waiting for, the post-test. The post-test will be made available shortly. Once you close the webinar, the post-test will come up. Please note that we do have one video that wasn't played by Sanfer, and then after that, I will share the post-test. So let me get into that.